guest, honorable host, and dear fellows. My name is Dr. Uruj Bhatti, and it's my honor to welcome you all for 33rd Annual Conference 2021 by Pakistan Society of Neurosurgeons. It has been said by Benjamin Franklin that an investment in knowledge pays the best interest. Liaquat National Hospital strives to achieve this investment by providing doctors a platform for sharing their knowledge. We deeply thank Professor Dr. Salman Sharif, Head of Department of Neurosurgery, for his efforts to keep us connected through various webinars and inviting intellectuals from all over the world during this long period of COVID, which could have halted our quest of knowledge. We now thank him again for bringing us back together for this conference and leading us to make it possible. It gives me great pleasure to see you all here. We have tried our best to make this time a valuable asset for your knowledge. Inshallah, all neurosurgery enthusiasts will enjoy. So let's start our program by recitation of Holy Quran, for which I would request to play.
Bismillahirrahmanirrahim. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
Jazakallah. Now we would like to start our conference with our first session, that is OV Juma lecture. I would like to invite Professor Rashid Juma, Neurosurgery Department, Aga Khan University Hospital, to come on stage and start the conference.
First of all, good morning, and I welcome everybody to the annual Neurosurgical Conference, which has finally taken shape after the interruptions. And I want to start by extending my appreciation to Salman for all the effort he's had of putting this together, despite all the pulls and pushes operating in the background. I also want to thank him for honoring the tradition of commencing each one of our annual conferences by the OVJ Memorial Lecture. And it's a great pleasure for me that today's lecture is going to be given by Professor Tariq Khan. Because if there's one thing that very strongly links Professor OVJ is that they have great interest and abiding contributions to head injury, the understanding, the epidemiology and management in Pakistan. So I think it's really fitting that you should be giving this. So I just want to say a quick word about Professor Juma, who was trained in the UK in Oxford and returned to Pakistan in 1951. And I want to share with you that there's a letter that I found in his belongings that came to him from his old professor in Bombay. And so obviously Professor Juma had written to him saying that, look, I'm in England and there's this new country called Pakistan, and they're asking me to come there and start neurosurgery there. What do you think I should do? And this professor, the general surgeon, wrote back saying that, you know, Pakistan is going to be a Muslim country, and therefore my advice to you, this, by the way, this is a Parsi gentleman, my advice to you is go back to Pakistan. So he did that in 1951, established the unit in JPMC, then Jinnah Hospital. And in a sense, along with Professor Bashir and Professor Raja, they really set the scene for Pakistan Society of Neurosurgeons. there was an early attempt in the early 60s, I think, I forget the date exactly now, with a meeting in Karachi. But there wasn't a regular takeoff from that. And then aided by Professor Javed Mia in the background, Professor Bashir then got together with Professor Juma, and they formally established the Pakistan Society of Neurosurgeons and the constitution and the logo and everything that you see now. So those are the contributions of our professional forebearers. And I now wish to turn to Professor Tariq Khan, who's our laudatory lecturer this morning. And Professor Tariq Khan trained in Belfast. And I guess the link to the head injury came that he trained in Belfast in the years that they called the Troubles. And the Troubles was a time of tremendous volumes of head injury. And there was a time when one of the busiest head injury services in the world was in Belfast. A lot of it, by the way, penetrating injuries. And having got that training, Tariq Khan came back to Peshawar. And in 1990, he joined Lady Reading Hospital. He joined the late, much lamented Professor Azaz Ali Shah, and the two of them established this very good unit. He then moved to Hayatabad in 97. And those of you who know a little bit about the neurosurgery in Peshawar know that Hayatabad is like a little boutique unit up in the north, a boutique neurosurgical unit. And a lot of the credit for setting that unit up goes to Tariq Khan. And then, of course, in 2002, the health department of KPK shot itself in the foot, and they lost the services of many of their distinguished medical practitioners, including Tariq Khan, who then moved into the private domain and has never looked back. Tariq Khan, we thank you for your leadership in the area of head injury in Pakistan and around the world. And I'd like you to invite you to come to the stage and give the OVJ Memorial Lecture. Tariq Khan.
Okay, Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Rashid Juma, for this introduction. I want to congratulate Salman Sharif and his team for organizing a wonderful conference, which took him a lot of time because of a lot of problems. You know, when Professor Obi Juma took over neurosurgery, the first neurosurgeon in Pakistan, since then, today, there have been great achievements in introducing precision neurosurgery in Pakistan by stereotactic, endoscopic, endovascular, et cetera, et cetera, et cetera. But sadly, the state of neurotrauma care hasn't advanced very much even since that time. And it's more because, I will explain to you, because most of those things which are required for management of head injuries and spine injuries is not in control of neurosurgeons. So if you look at this map, which is being updated regularly by the World Federation of Neurosurgeons, you can see the red areas are the areas where there is dire need of neurosurgeons. And I think you need about 22,000 neurosurgeons in the world or more, and most of them are in the lower and middle income countries. And if you look at this thing from Key Park and his team, that 74% of surgeries for TBI are needed in the LMICs, and these are the surgeries which are needed, not the ones which are done. If you look at it, that 89% of spine trauma is in LMICs. So there's a lot of burden and very few neurosurgeons available. So how to cope with this large influx of head trauma? And I think it's important that you should innovate and integrate into the health systems of the universal health coverage. And for that, you need a holistic approach for getting that. And you need to talk about prevention, pre-hospital care, emergency room care, ICU, theater care, ward care, and then the most important thing, rehabilitation. So the two most important things, the prevention, or three, the pre-hospital care and the rehabilitation are the ones which are not in control of the neurosurgeons here. I'll just take you to a little survey which was done by Asian Association Society of Neurosurgeons, and it was our hospital in Peshawar, a few hospitals in Indonesia, and a hospital in India. And if you look at the survey which we did regarding the seat belt and the helmet, and we can say that the majority of the people who had come to these units were not wearing any seat belt or helmet. And if you look, the reason, and we think that, we have to get into the Guinness Book of World Records by putting as many people on a motorbike, and we think that one helmet is going to, really look after everybody. So the most important thing, we started talking about prevention, and in 1997, when I moved to Hyderabad Medical Complex, Dr. Shahid is there, he was one of our first trainees, and we started on this project. And we did a lot of seminars, webinars, and walks to prevent head injury, and public awareness seminars. And then we made it mandatory that every neurotrauma meeting must have a head injury prevention symposium, and which we carried on for some time, but then the neurotrauma meetings vanished for some reason. And then the World Federation of Neurosurgery Neurotrauma Committee, of which I am the chairman, we decided to get together with Think First International for injury prevention. Think First International, one of the biggest organizations in the world for head injury prevention. And we did our first seminar for prevention of neurotrauma in Peshawar in our meeting in ICRAN, and more than 1,500 people attended that from the public sector. Then the other part of the survey was who provided emergency treatment at the scene of injury. And again, we saw that most of them were lay people, pedestrians who helped other people. There was no nurse or no paramedic available. And then we looked at if a nurse or doctor accompanied the patient in the ambulance. And we know that literally the ambulances have neither oxygen nor suction nor any paramedics available in that. And we also know that it's very important that the first few hours are very important, and a lot of deaths are preventable. 40% of them are preventable if you bring them in time. And if you look at this, comparing the high-income country and the lower middle-income countries, that how many people arrive in time for to the neurosurgical units. And then also very important, the time taken for surgery for a patient with a head injury. So this is not the time when they reach the hospital, it's a time from where they arrive from the peripheries or different places. And you can see that a lot of them are operated on more than 24 hours later. So management is geared towards prevention of secondary injuries and rehabilitation. Secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality. So the longer the delay, the greater the mortality. So I think it's very important to establish good ambulance services. I think the government has done a great work in this. I think in Karachi, the Aman Foundation, I believe, has done a very good job. In Peshawar and Punjab, 1122 have done a very good job, but they need to do a lot more. And then guidelines. I have been crying for the last 20 years or more so about developing guidelines for neurotrauma care, right from the place of accident to the rehab. But unfortunately, nobody has listened to me. I think it was many, many years ago, I presented this in Lahore. We developed a guideline book, but people did not follow really. And the guidelines have to be tailored to our needs. There are golden guidelines, excellent guidelines of high-income countries, but we can't look at that because of geography, the profile of the injuries and all that. So we need to develop our own guidelines. And we commissioned Professor Rubiano from Columbia, the Neurotrauma Committee asked him to develop guidelines, and they developed beyond one option for treatment of traumatic brain injuries, a stratified protocol. Depending on the type of hospital, type of ambulance, they developed that. And we wrote a commentary on that. And it was a paradigm shift from standard-driven protocols to resource-driven protocols. So you cannot be stuck to one thing that if you can't have those golden treatments, then you cannot develop guidelines. No, we can keep on improving on those guidelines. So then in-hospital management is guided by, you all know, by GCS monitoring, by CT scans, by ICP monitoring, pupillary response, and the goal is supportive treatment and prevention of secondary damage. And you all know about the Brain Trauma Foundation guidelines of elevation of the head, et cetera, et cetera. And you also know that the Brain Trauma Foundation recommends that there's level 2 evidence that bifrontal decompressive craniectomy has shown to reduce ICP, but the extended outcome in 6 months is still the same. And that if you are going to do a decompressive craniectomy, it has to be a large flap, a big flap, at least 12 by 15 centimeters. And ICP monitoring can reduce the hospital stay in ICU. But if you look, this is the ICU bed in a high-income country, and this is an ICU bed in a lower-income country. So what about the guidelines for in-hospital guidelines? So majority of the severe traumatic brain injury patients globally are managed without ICP monitoring. And there's no recent literature to guide management in non-monitored patients. And large parts of literature come from well-equipped large centers in higher income countries. It's unfortunate that the biggest head injuries is there in the lower and middle income countries, and very few papers, statistics come out of the lower and middle income countries. And there is no resource-based guidelines in LMICs. So there was a best strip trial by Professor Randy Chestnut. Those of you who were in Peshawar in 2019, you must have met him. And he had done a lot of work on neurotrauma in countries in South America with no ICP monitoring. And this was compared the ICP monitored patients to non-monitored, and they were done by imaging and clinical examination called the ICE protocol. And then they wrote a paper on a consensus-based management protocol for the treatment of severe brain injuries, where ICP monitoring was not employed. It's not a substitute, but a supplement for empirical evidence. And this is effort to provide for the vacuum left by absence of evidence-based guidelines. So in Peshawar, in Northwest General Hospital, how are we doing it? There are patients who come in whom we feel they need straight away a decompressive craniectomy. Then there are patients whom we monitor ICP through an intraventricular catheter. And then depending on the response of the ICP to drugs, etc., we decide whether we want to do a decompressive craniectomy or not. Or if we cannot do the ICP monitoring, then we follow the ICE protocol. So what are our indications for decompressive craniectomy? So findings of diffuse brain edema, effacement of cisterns, midline shift, GCS of 9 to 12, 2 degrees from previous, and age less than 70. Some of my friends question me about that, because as we grow near 70, we wonder whether we should be treated with a decompressive craniectomy or not. But it's a higher mortality, obviously, the older you are, but depends on how fit you are, I suppose. So age is, cannot be the exact criteria. And the Crevice protocol then we follow, and that is basically based on the Marshall score on CT brain, the interval CT scans, the clinical score, GCS, neuroversing, and the pupillary response. And it's a 4-tiered management. So you all know the Marshall grading. I will not go into that. And then the criteria are there. On the neuroworsening is when GCS is 1, reduces 1, then more, or if you lose pupillary activity, etc. And imaging schedule is important. So what we do is that after 24 hours, we stop the sedation, we do the clinical examination, look at the pupillary response, and then do a CT scan. And then depending on the CT score, we either put him back on the ventilator or take him for decompressive craniectomy or reduce the ventilation. And this is how we do it by initially giving hypertonic saline, etc. So these are different tiers, where tier 3 is decompressive craniectomy. So we escalate the therapy if there is neuroworsening, there is no improvement or worsening on follow-up CT imaging, or no acceptable response to initial therapy. And this is just the matrix. And the important thing is talking about weaning from the ventilator. So we have different scores. Look at the Marshall score, look at the pupils in the motor response. And if you look in the first 24 hours, it's all red. So very few people can be taken off the ventilator. Then slowly you have more chances. So it's a more standardized looking at when and how to do that. And I wonder if we can ever have a study for this. You know that there was a consensus meeting on decompressive craniectomies, and I would recommend to all the young neurosurgeons that they should study this paper, which shows you when and how to manage by decompressive craniectomies. So we looked at then also in this Asian Australasian survey, we looked at rehabilitation, and which is the most important part of neurotrauma care. And we found that majority were sent home, as you know, and there was a very good paper from Aga Khan University where they talked about training the relatives to give rehab at home. Those of you who were in Peshawar, we developed these comprehensive policy recommendations. These were for civil servants, for the government, and these were made by the Harvard University, by Key Parkins Group, and by Northwest School of Medicine, our group. And these we were able to put onto the National Vision for Surgical Care, Pakistan 2025. We were able to put head injury onto the National Vision, which was a very big achievement for us, because whenever the National Vision comes into force, which is part of the universal health coverage in the country, it's going to be on that. And our plan was that in Bogota, we should have reached a certain level. Then we talked about global neurosurgery and, the launching of the Global Neurosurgery Committee. And that, again, is a very important thing that people now know more about global neurosurgery. And it is to achieve universal access, to align and coordinate all global neurosurgery activities. There are a lot of activities going on internationally, in Africa mostly, in other countries where people are going on their own. They all have been consolidated together. And to engage with surgical stakeholders for building integrated surgical care systems. This is just something which a lot of people have been talking about, task sharing, task shifting, whether it is a good idea to train general surgeons to do trauma or not. It is something which is very debatable. It has become much easier now because of Skype, because of Zoom, because of, you can control the surgeons and help them do surgeries. Thank you very much for that.
Tariq Khan, thank you very much for that overview of your work in the area of head injury, and quite honestly, the progress that has been made by people like yourself coming together to share experiences and evolving common answers to some of the contentious and more difficult issues relating to the management of head injury. It's not customary to have questions at the end of a memorial lecture like this, but if one of our senior members wants to make a comment, please feel free, and if not, then it remains for me to thank you on behalf of the society, sir, and we hope that you'll continue to lead the charge and from Pakistan on head injury management as you've done in the recent past.
Thank you. I hope the young neurosurgeons need to come forward and take this on. I think, again, I stress prevention, rehabilitation. We should not get worried that we cannot do ICP monitoring. That's only part of it. There's many other things to it. So please, thank you.
Tariq Khan, as you step away, something comes to mind which I just have to let out and share with you. When I came back to Pakistan and I started working, and Dr. Juma was talking to me one day and said, so what is it that you want to do? And I started talking to him about Harrington rods, which was the great implant that I really want to start putting in Harrington rods into people. And he said, you know, the community expects from the neurosurgeon the best in head injury care. And that's what people like you should be concentrating on. And I was very embarrassed by this, and it stuck in mind, and you just reminded me of that now. That's what the community expects from the neurosurgeons, good head injury care. Thank you, Tariq Khan.
So thank you very much for this brief introduction and nice talk on insights about the traumatic brain injury. So with this, we would like to end this session. Thank you.
Thank you, Dr. Rashid Juma and Dr. Mohammad Usman and Dr. Tariq Khan for this wonderful session. Now we would like to move on with our second session, Iftikhar Ali Raja Memorial Lecture. The chairperson for this session would be Dr. Muhammad Anwar Chaudhry, and the moderator would be Dr. Khola Azmat. We have Dr. Hassan Sayed from US, who is going to give a talk on global resident burnout. He will be online with us through Zoom.
Assalamu alaikum, everyone. Everybody knows the great neurosurgeon Professor Iftikhar Ali Raja late. He was the founding member of ACNS, Asian Congress of Neurologic Surgery, and he was also founding member of Asian Oscillation member, which was a big international society. Credit goes to him that he introduced Pakistan neurosurgery everywhere in the world. He was one of the most active member of Pakistan neurosurgery who used to travel all over the world for the academic purposes. And he was a person who raised the name flag of Pakistan the world over. We miss him a lot. May Allah bless him in the Jannah. Now we invite straightaway our presenter, Dr. Hassan Sayed from USA, Global Resident Burnout. Topic is Global Resident Burnout.
Hello, my name is Hassan Sayed, and I'm really excited to be here with you today, I guess this morning in Pakistan. I was very fortunate to visit Pakistan in 2020 when the Karachi spine was going on. And again, thank you for giving me the opportunity to be here with you. My talk today is focused on education. I'm a neurosurgeon in America with a subspecialty focus in pediatric neurosurgery, but I've always been really a proponent of education and involved with resident education as well as our own fellowship in pediatric neurosurgery. But the title of my talk today is Work-Related Factors on the Risk of Resident Burnout, something that we've all heard about, and this is sort of a pilot survey that I wanted to share with you all. So I have to acknowledge my co-authors as well, Natasha Ironside, who's a third-year resident at the University of Virginia, Rocky Feldbaum, who is a cerebrovascular and endovascular neurosurgeon at Georgetown, where we both trained, as well as Walter Jean, who was our program director at the time, who some of you may know as well. He's now the chief of neurosurgery at Lehigh Valley in Pennsylvania. So as I mentioned, we've all heard about this concept of burnout and physician burnout, but I think it brings about different ideas depending on where you are geographically, and also you know, what country you're from and what the resources are available. And even with COVID now, the concept of burnout has become more prevalent. So let me first start out in terms of describing what burnout is, and then taking us forward in terms of the study that we conducted. So burnout, as we know, is a syndrome that's characterized by emotional exhaustion, depersonalization, and a decreased sense of efficacy. It's something that we know from previous research that is present in trainees all across the world for different reasons. And in fact, our accreditation board, the ACGME, takes this into consideration, and in 2017 actually reaffirmed the 80-hour work limit, which is what is standard in America for resident training. But the ACGME really has had an increased focus on resident well-being, as well as fostering a culture of respect, accountability, and support in the clinical environment. So why is burnout important? Why are we talking about this? Well, there are many factors related to burnout, some that we have control over as educators, and some we don't, but these include demographic factors, work-related factors, as well as personal issues or concerns that come up in each of our trainees' lives. But ultimately, this can have an effect on patient care and lead to medical errors, job attrition, depression, and sadly, suicide. So really the questions are our residents right to demand attention to wellness, and does it actually make a difference? Or is this just a harassment of program directors and educators? So we sought to really investigate this with the following questions. How many neurosurgery residents are at risk for burnout? And is there a difference across the globe? What work-related factors drive burnout or reduce it? Is there a difference in the effect and strength of these factors around the world? And finally, are trainees in low to middle income countries more likely to be at risk? So we devised a 16-question survey that really asked the respondents program characteristics and work-related conditions. And we also took this survey called the Maslow survey that really has been validated as a tool to measure burnout. And these 6 questions focused on emotional exhaustion, depersonalization, and the sense of personal accomplishment. The responses were then collected on a 5-point Likert type scale, and a score greater than 18 was deemed at risk for burnout. This was the results from our survey. There were 797 respondents from 93 countries, with over 240 respondents from low to middle income countries. This is a map that sort of illustrates the respondents, and we were very thankful. We had 26 respondents from Pakistan. The color red describes the non-LMIC countries, and the green are the LMIC countries that responded to our survey. Again, this is just a pie chart describing the results by geography, and you can see 39% of our respondents were from Asia, followed by 25% from Europe, and then 14% from North America. So I wanted to just briefly go through the 6 questions that looked at the burnout concerns. So question 1 really focused on the frequency of our respondents feeling frustrated. So the majority, 52%, felt frustrated sometimes, but more specifically, 23% of the respondents usually or always felt frustrated. In terms of feeling happiness or satisfied with their jobs, you can see the large majority were satisfied with their job. Question 3 focused on the feeling of being stressed at work, and approximately 38% of respondents described usually or always feeling stressed at their workplace. Question 4 basically focused on the feelings of being tired, or the fact that respondents didn't care to what happened to their patients, and 9% respondents agreed or strongly agreed with that statement. In terms of the work environment, 31% of our respondents felt that their work environment was hectic, chaotic, or out of control. And finally, question 6, 6% of the respondents did not believe that they had a positive influence on their patients or their coworkers, or their work environment was a positive influence. And finally, the 6% also felt like their training was headed in the right direction. In terms of the key findings, our global cohort, in terms of the global cohort, the average total score from the 6 burnout questions was 15.8, and the at-risk from the global cohort was about 21% that were at risk for burnout. As we can imagine, the drivers for burnout included frequency of overnight call, the total work hours greater than 80, consecutive hours worked, and interestingly, less than 100 operative cases in the last training year. So when we look at the results in more detail in terms of how geography influenced these findings, we saw that US and Canadian trainees, approximately 40% reported 300 operative cases in the past year. 64.8% of these trainees worked over 80 hours per week, which of course the ACGME would find surprising because that is technically the limit, the official limit. When we look at the Europeans, they reported approximately 29% reported less than 100 cases that the trainees were involved in the past year, and they were more likely to have less frequent than Q3 call. As we can imagine, Asian and Latin American trainees were more likely to have every other day call, and 22.6% of Asian trainees worked greater than 120 hours per week. So this is a table that really describes the intercontinental differences in the risk for burnout. And I want you to focus on Europe and US and Canada. So Europe, 26.9% of residents in that location were at risk for burnout, compared to 11.2% in US and Canada. And so you all might be wondering, like, how is that possible? Globally, work hours and overnight call are burnout drivers. However, the European trainees have a 48-hour work week. So why do they have the highest burnout score and the highest percentage at risk for burnout? And the reason for this, at least what we think, has to do with the data that we analyzed, and that goes back to the number of operations that these trainees have been involved in last year. If you look at the US and Canada, those trainees who were involved in 100 to 300 operative cases were actually a driver for burnout. Whereas in Europe, those trainees who were involved in 100 to 300 cases, that was actually a protector for burnout. So this probably has to do with the operative cases and trainees feeling that the more they operate, the more positive their training is, and them sort of advancing their career goals. So operative experience and burnout risk, we saw that 28.6% of European trainees were involved in less than 100 cases. Those trainees have a higher burnout score compared to other European colleagues, whereas 40% of US and Canadian trainees operated in greater than 300 cases in the past year, but were less at risk for burnout. Looking at low to middle income countries compared to non-low to middle income countries, as we can imagine, these trainees were more likely to work over 80 hours per week, had more total hours per week, and more likely to take call every other day. This is just a graph sort of explaining the difference between these questions between low to middle income countries versus others. And the fact of the matter is most of the responses were similar. However, low to middle income countries were more likely satisfied with their workplace, but described their environment as more hectic. So despite that, low to middle income countries had identical burnout compared to low to middle income countries. And that was quite surprising because these trainees are working harder, longer hours, and more often on call. So again, why do they have identical average burnout scores and percentage at risk compared to the rest of the world? And our explanation to this is the fact that LMIC trainees may be immune to these global drivers. And this all relates to comparative perception and potentially the concept of grit, which you all may heard of. This is really described as a continued fortitude in the face of hardship, and as well as perseverance of long-term goals despite adversity. So this may play a role in the resilience that neurosurgical trainees experience from LMIC countries, and something that we can all learn from. Certainly, there are limitations of this study, as there are with all surveys. This was also a truncated survey and wasn't validated, but definitely I think we can all learn some things in terms of what low to middle income country trainees are motivated from, and something that we can pass on to our own trainees. So really the conclusions are work hours and on-call duties drive burnout throughout the world. The impact of these factors differ geographically, as we talked about. Operative case volume has a significant impact, and the paucity of operative experience may be a more powerful driver to burnout than work hour restriction is a protector against it. Trainees become more resilient to working long hours if they perceive their operative experience to be advancing their training goals. Finally, LMIC residents really experience and show us the concept of grit and resilience. And perhaps, from the US, our accreditation council is vindicated because of the US's, the US trainees sort of work hours and their burnout risk. Again, I want to thank you all for giving me this time to share this work. I'm happy to answer questions. Again, I thank the organization committee. I also want to thank Dr. Salman for all the work that he's done and the introductions that I've had in terms of meeting everyone from Pakistan. And I hope that I can visit you all very soon. Thank you.
Thank you, Dr. Hassan Sayed, for a very nice, informative lecture.
We hope we will see you in the Pakistan next time. Thank you very much.
Inshallah. Thank you.
Thank you. Thank you.
Thank you, Dr. Muhammad Anwar Chaudhry, and thank you, Dr. Hassan Sayed. Dr. Khala, I would request you to please be seated. Now we are going to move on to our oral abstract presentations, for which I would like to call Dr. Khalid Mahmood for chairing this. Dr. Iqbal Ahmed Kharal as a co-chairperson, and Dr. Khala Azmat for moderating this session. The first group that we have is from Punjab Institute of Neurosciences, Lahore. The team members are Dr. Anam Fatma, Dr. Zubair Mustafa Khan, and Dr. Asif Bashir. They are going to talk about visual outcomes and extent of resection of giant pituitary macroadenomas through endoscopic excision, and experience from a tertiary care center of Lahore, Pakistan. Presentation. Visual outcomes. Sorry? Yeah, visual outcomes.
Bismillahirrahmanirrahim. My name is Dr. Anam Fatma, and I am resident from Punjab Institute of Neurosciences, Lahore. Today, I'm going to present on visual outcomes and extent of resection of giant pituitary adenomas, experience of a tertiary care center. So before going into the detail of my research, just a brief introduction about the topic. Pituitary adenomas constitute about 10 to 15% of all intracranial tumors. Although they are benign in pathology, but the location of pituitary adenomas make the treatment very challenging. Traditionally, it has been operated through transcranial approach, but the first transsphenoidal resection of pituitary adenomas was started by Harvey Cushing in 1980s. So what is giant pituitary adenoma? It's a tumor which is greater than 4 centimeters in maximum diameter, and it mostly presents with neuro-ophthalmological symptoms and hormonal dysfunctions. Despite of advancement in neurosurgical techniques, giant pituitary adenomas still pose significant surgical challenge. Still, there is no consensus on surgical technique to address these tumors because of their close vicinity of optic nerves and to the major vascular structures. These are the main restricting factors in the surgery. So what is the basic aim in resecting this tumor? It is to remove the tumor with minimal possible side effects. The possible surgical techniques are transcranial approach, endonasal endoscopic transsphenoidal approach, and the combined approaches. Endoscopic transnasal transsphenoidal approach is preferred for pituitary adenoma of any size. So coming towards the study, there were two main objectives. First was to find out the visual outcomes after giant pituitary adenoma resection, and second was to find out the extent of resection of giant pituitary adenomas. It is a retrospective case series done at Neurosurgery Department 3, Punjab Institute of Neurosciences, Lahore from 1st January 2018 to 31st December 2020. Sample size was 50. Endonasal endoscopic transsphenoidal approach was used for all patients. Visual outcome was assessed as visual status was assessed as visual acuity and visual perimetry, which is done by an ophthalmologist. Extent of resection was calculated through Hospital PAC's online system preoperatively and postoperatively from brain MRI with contrast, done 3 months postoperatively. Now coming towards the results. Majority of the patients were females. Mostly the tumors were non-functioning tumors. Only 10% of the tumors were functioning tumors. Among the functioning adenomas, majority of them were growth hormone secreting adenomas, and only one tumor was prolactinoma. Extent of resection, we were able to achieve 36% in 36% of patients near total resection, in 44% of patients subtotal resection, and in 20% partial resection. Visual status comparison, 3 patients had total blindness and there was no improvement post-operatively. Among patients who had monoocular blindness, there was improvement in 43.3% of patients. 47 patients had field effects and 75% had improvement after the resection of tumor. Among the patients who had visual field outcome, improvement was in 75%, deterioration was in 10%, and same visual field status was in 15% of the patients. There was one patient who expired. He developed post-operative CSF leakage. Endoscopic repair was done, but patient expired due to development of meningitis. So these are some of the pictures from the patient's MRI. This is the pre-operative scan showing the tumor. This is the post-operative scan of the same patient. This is another patient. Post-operative scan of the same patient. This is another case. This is the post-operative scan of the same patient. Again, the pre-operative scan and the post-operative scan showing complete resection. Now the literature review. So J. Harvey et al. Reported similar results in their meta-analysis, quoting that non-functioning adenomas being the most common giant pituitary adenomas. And among functioning adenomas, they also reported that only growth hormone and prolactin secreting tumors reach a size greater than 3 centimeters. In a study by Amit Murat et al., visual field effects improved in 74.1% of patients as compared to our study, which reported 75% improvement in visual field effects. Duration of visual symptoms in our series was more than 6 months in most of the patients. Menel et al. Reported an extent of resection of 41% gross total resection and 20% subtotal resection, which is comparable to our results. Now the conclusion. Relief of mass effect by obtaining maximal tumor resection in order to decompress visual pathways and neurovascular structures and the pituitary gland. And the second is the transsphenoidal endoscopic endonasal surgery may provide effective treatment for patients with giant adenomas when performed by a surgical team that specializes in pituitary surgery. So here's a small video of the lateralization of the metal turbinate. In the drilling part, and then opening of dura and then tumor section. This is the post-operative scan of the same patient. Thank you.
Are we going to ask the questions at the same time, or is it at the end of the session? Okay. All right. Okay.
Thank you, Dr. Anam Fatma. Now the next presentation would be by Dr. Javeria Khan. She's from Punjab Institute of Neurosciences, Lahore General Hospital. She's going to talk about efficacy of endoscopic endonasal approach for biochemical cure in functioning pituitary microadenoma.
Correct that.
आपको USB
As the things are being set up, I would just like to ask from Anam, do you, based on the results of your 50 cases with the giant pituitary adenomas, have you sub-analyzed the failure of optimal results in your case, and what are your recommendations when you should go for transcranial approach for these giant tumors? Anam, are you here? Yeah. So what do you recommend actually? What would be the indication for transcranial approach for giant adenomas if you're not removing them properly?
So first we can go for endoscopic approach, then if there's no improvement.
What would be the contraindication for endonasal approach for giant pituitary tumors?
So if it's encasing the carotid, cavernous sinus, if there's paracellular extension of the tumor, then we can go for subtotal resection in that cases. And for giant adenomas, we can recommend that in first surgery, we can go for endoscopic approach. And if there's no improvement and patient still has symptoms, then the second approach can be transcranial approach.
And what did you do with those tumors which were left? Okay.
Assalamu alaikum. My name is Dr. Javeria Khan from Punjab Institute of Neurosciences, Neurosurgery Unit 1, and I'm really honored to be given this opportunity to share with you our work about the efficacy of endoscopic approach. It's not moving. मेरे पास चल रही है। Sorry. So we are discussing the efficacy of endoscopic endonasal approach for the biochemical cure of functioning microadenomas. As we all know that pituitary adenomas are the most common intracranial adenomas, and they represent 10% of the intracranial neoplasms. In our unit, over the last 7 years, total 616 cases of pituitary tumors were operated. In these, there were 226 tumors that were functioning, and 390 patients had non-functioning tumors. And out of these 226 cases, we have selected only a subgroup of tumors with size less than 1 centimeter, that is microadenomas, and there were only 26 cases of these. So there are 4 basic types of microadenomas which are functioning. Growth hormone secreting microadenomas are the most common microadenomas that present for surgical management. Their medical management is very prolonged and very expensive. So these patients, they stop medical treatment due to socioeconomic problems. The second is cortisol secreting microadenomas, and they most commonly presented in our setup and were treated surgically. Thyroid secreting hormones, they were the most rarest type of microadenomas. Prolactinomas are the most common microadenomas, but they are mostly treated medically. 98% cure rate is with medical treatment, and they are rarely treated surgically. So we have two treatment options for microadenomas: endonasal endoscopic transphenodal approach and microscopic approach. And endoscopic approach has been becoming the treatment of choice for biochemical cure. The objective of our study was to determine the efficacy of pure endoscopic endonasal transphenodal surgery for the biochemical cure of functional microadenomas. It was a retrospective case study. 26 cases out of 616 total cases were selected. It was conducted over a period of 7 years, and follow-up was for about 1 to 7 months with a mean of 3.5 months. Twenty-six patients were selected, and their demographic, endocrinologic, and radiological features were studied, and their complications were assessed in these patients. Follow-up was done with MRI brain with contrast and our hormonal profile after 6 weeks. A large number of patients were included with age group ranging from 15 to 70 years. Tumor size was less than 1 centimeter in size. Hormonal profile was deranged, and patients who are medically fit to undergo surgery were included in this study, whereas the patients who had prolectinoma, conchal type of sphenoid sinus, that is the sphenoid sinus has very thick bone, recurrent cases of microadenoma, patients who were not fit for endonasal approach due to any visualization hindrance or pathology of nasal passages, or patients who were medically unfit to undergo surgery were not included in this study. Pre-surgical requisites that we got an MRI of the patients with pituitary protocol, that is 1 millimeter thin slices without gap, and field of view was focused on sella. CT brain plane with FES protocol was obtained, in which 3 millimeter or thinner slices with sagittal and coronal reconstruction were obtained. Hormonal profile and consultation with endocrinologist was our first priority. Evaluation of patient regarding endonasal approach and anesthesia fitness, so we consulted with ENT specialist and anesthesiologist, and informed consent of the patient. So total 26 patients were selected. 18 patients were presented with cortisol secreting hormone. 7 patients were presented with growth hormone secreting, and only 1 patient was presented with thyroid secreting hormone. 15 patients were female and 11 patients were male. So there was a female predisposition in this microadenoma.
Dr. Javeri, only 1 minute is left. Please be quick.
61 to 70, this is the age distribution of the patients. This is an MRI of the patient, in which you can see that there is a right-sided microadenoma. This is the CT FES. These patients have a small sella. That is why endoscope is very helpful in localization of the tumor. Extracapsular resection is the basic principle of this surgery. These patients have an interface of normal pituitary along with the compressed normal pituitary and the adenoma, which is known as pseudocapsule. This is our plane of surgery. This is a pictorial depiction of this procedure, in which we dissect the plane between the normal pituitary and the tumor and resect the tumor extracapsular. This is the FES endoscopic view of the sella. This is a video in which you can see that we are removing the floor of sella. Then dura is opened in a cruciate manner. After opening the dura, we mark a very precise incision separating the normal compressed pituitary from microadenoma. We dissect in this plane. Then the tumor is resected with pituitary biopsy. Complete resection is done, and ring curette is used to clearly clear the margins, anterior and the lateral extensions of the tumor. So out of these 18 patients, the patients with cortisol secreting hormone, 13 patients achieve biochemical cure, while 5 patients have to be referred to endocrinologist. In growth hormone secreting patients, 4 out of 7 patients have been cured, while the rest were referred for endocrinology and radiotherapy, and 1 patient with thyroid secreting hormone achieved biochemical cure. The patients who had residual tumor, they were referred to radiotherapy and medical therapy. And after 6 months, this is the post-op, some of the post-op complications. After 6 months, 12 patients were still on radiotherapy and medical treatment, while 81 patients have achieved medical cure. This is a 1-year post-op picture of the same patient. So our conclusion was that the endoscopic approach is a safer and better approach for treatment of microadenomas because it has a bloodless surgery. There are less side effects. And if we reduce the microadenoma size, so the post-op radiation dose and the recurrence rates, they can be controlled. Thank you.
Okay, shall we move on to our next presentation? The next presenter is Dr. Amanur Rahman from Punjab Institute of Neurosciences, and he's going to talk about outcome in cerebellopontine angle tumor surgery using electrophysiological monitoring for the preservation of facial nerve. Okay, I would like to request participants to try completing their presentations in 5 minutes because we are already running out of time. Thank you.
Assalamu alaikum, everyone. I'm Dr. Amanur Rahman, a resident neurosurgeon at Punjab Institute of Neurosciences, Lahore. Today I'm presenting my topic on outcome in cerebellopontine angle tumor surgery using electrical physiological monitoring for the preservation of the facial nerve. So why facial nerve monitoring is important? Intraoperative facial nerve monitoring aids in localizing the nerve displaced by the tumor, detect nerve injury during dissection, provide means of assessing nerve functions after dissection is completed. Since Paris in 1986 introduced the direct electrical stimulation and loudspeaker monitoring, it has been the gold standard for intraoperative facial nerve monitoring in CP angle surgeries. So the location of the tumor is important. It's usually adherent to the facial and vestibulocochlear nerve. The CP angle tumors involving the facial nerves are usually schwannomas and meningiomas. And the 3 approaches regarding the, related to the CP angle surgeries. Well, the most important thing is the surgical complications. Hearing loss and facial paresis is the most main complications related to these surgeries. Well, this is the descriptive study which was conducted in the Department of Neurosurgery Unit 2 for the period of 3 months from November 2020 to January 2021. Currently, no regional data has been recorded regarding the intraoperative facial nerve monitoring. We take a sample size of 10 cases, and House and Breckman grading of the facial nerve was recorded, and retrosegmoid surgical approach was the main approach for the tumor resection. We exclude the extremes of ages, and we take patients with having grade 1 and 2 facial nerve paresis. Post-operatively, we evaluate the patient after 48 hours and after 7th day. Well, the mechanism of facial monitoring, we use 2 lead monitoring. One was placed at orbicularis oculi and the other was at oris. The electrical probe was used to stimulate the nerve. These are the nerve patterns when we stimulate the nerve and when the tumor is being resected or distorted. Some protocols we need to follow. We can't use long-acting muscle relaxant, and we need to stimulate the nerve at early point of the surgery before any significant nerve manipulation is performed. These are the nerve leads we performed. The intraoperative view where we have to stimulate the nerve. Well, this is the nerve waveform when the nerve is stimulated. So the pre-assessment of the patient was taken, 10 patients with having 1 and 2 injuries. The post-operatively, we have the efficacy of 70%. Grade 1 having, there was no injury in the, for 4 patients, and 3 patients have grade 2. After 7 days, the results were the same. We have 70% efficacy. Good facial nerve functions, grade 1 and 2 was observed in 7 patients among the 10 patients we have operated. Several studies has been investigating the correlation of the intraoperative facial nerve monitoring. And recently in 2005, there was a study in which 75% patient facial, 75% outcome was observed in the patients with 6 months follow-up. To conclude, the intraoperative facial nerve monitoring in modern microneurosurgical technique has led to a dramatic reduction in the morbidity once associated with the severe angle tumor surgery for the facial nerve injury. It improves the quality of patient life and aesthetics of the face after the surgery. These are some references. Thank you very much.
Thank you, Dr. Rahman. Now we are going to move on to the next presentation. I would like to call Dr. Mubashir Malik from Punjab Institute of Neurosciences, Lahore. He is going to talk about fluorescent-guided resection in neuro-oncological surgery.
Bismillahirrahmanirrahim. I'm Dr. Mubashir Malik from Punjab Institute of Neurosciences, Lahore, Neurosurgery Unit 2. Today I'm going to present on a topic that is the fluorescent-guided resection in the neuro-oncological surgery. So what are the challenges for the neuro-oncology? As you know, most of the talk over here in this conference is also for the tumors, brain tumors or spinal tumors, etc. So what we face more difficulty, that is during peroperatively, we are unable to identify between the normal and the tumorous tissue in the most of the tumors. For example, most common is the glioblastoma multiforme or the metastasis. As we counsel the patients as well in preoperatively, as that in our late term language is that ye jodon wali rasoli hai. So it is the infiltrating tumor into the normal brain tissue. So we cannot have some gadgets previously for the differentiation between the normal and the diseased portion of that brain or the tumor. So our study is based on the fluorescent guidance during the surgery while operating that kind of the tumors. There's a little introduction and the literature review in which it shows that the glioblastoma multiforme is the most common primary brain tumor, and it's very aggressive with the incidence of 12,000 new cases each year. So the treatment of these tumors is the gross total resection, and in such to perform these tumors, we use some adjuvants to the surgery. And these surgical adjuvants are the intraoperative ultrasounds, intraoperative MRI, flare attenuated this MRI sequence, then the neuronavigation, cortical mapping, and the fluorophores. That is the sodium fluorescein and the 5-aminolevulinic acid, known as 5-LA as well. So the GTR improves in the patient survival and reduce the morbidity and in newly diagnosed cases of the glioblastoma multiforme. So the current standard of the surgical treatment is the maximal safe resection. The most common used technique while using the intraoperative fluorophores is the fluorescein. And the fluorescein guided resection is also beneficial in the other tumors of the brain and spinal cord. For example, the metastatic CNS tumors and the atypical meningiomas as well. Objective of our study is to establish that the fluorescein guided resection in oncological surgery is beneficial in terms of tumor identification and the gross total resection peroperatively. These are the material methods in each. This is a quasi-experimental trial conducted at the Department of Neurosurgery, and its ongoing trial after the ethical committee approval. Inclusion criteria and the exclusion criteria is given here, in which we taken these patients. So this is the procedure, all procedure done by the same surgical team in the Neurosurgery Unit 2, Punjab Institute of Neurosciences. We used the 25% of the fluorescein solution, and dose was the 10 to 15 milligram per kilogram, and we give that dose at the time of bone flap removal, that is the craniotomy. So the extent of the resection of the tumor under the fluorescein guidance will be noted under the perioperatively and will be confirmed for post-operative MRI or CT scan as well. So these are the results from our study in which the major group of age distribution and the gender distribution. So the most of the cases were in the age group of 15 to 30 years of the age. This is the wheel representing about the cases, and you can appreciate the major portion of the wheel having the brain's gliomas, which also includes the GBM metastasis and the low-grade gliomas as well. This is the distribution by the type. So the high-grade gliomas were, we are presenting the 13 cases from our series, and 9 were the high-grade gliomas, 2 were the low-grade gliomas, 1 was the spinal tumor, and 1 was the atypical meningioma. And we achieved 84.6% of the gross total resection, that is more than 95% of the tumor we excised while using this fluorescein intraoperatively.
Dr. Mubashir, please be quick, only 1 minute is left.
Yes, not a single case of fluorescein toxicity, that is the renal damage or the anaphylactic reaction is observed, and this proving the safety of fluorescein in the CNS tumor surgeries. So these are the cases we are presenting from our series. This is preoperative. This is the intraoperative scan. You can appreciate the tumor bed, which is enhancing after the uptake of the fluorescein. And this is the postoperative scan. This is another case with the high-grade glioma in the occipital region. This is the postoperative scan as well. So at the end, the fluorescein guided section of the glioblastoma multiforme and the metastatic brain tumors proved effective in the cross-total resection. In our study, GTR achieved in the 84.6% of the CNS tumors. And this is the references from the other studies which our results were comparable. The point to be noticed that that dose we use, that is 10 to 15 milligram per kilogram, is the dose at which we can achieve more gross total resection as well as compared to the other studies. They achieved the 75%, 80%, and the 80%. Respectively. So conclusion is that the fluorescein guided resection for the complicated tumors like the high-grade gliomas has shown promising results and easily available with a short learning curve for the young neurosurgeons at the centers where the fancy gadgets like the neuronavigation, intraoperative ultrasound, cortical mapping, etc. not available. So improving the patient's care in terms of less morbidity and the mortality. For the resection of the CNS lesions like the spinal gliomas, spinal metastasis, lymphomas, meningiomas, and the cerebral abscess, fluorescein can be a future tool for the maximal safe resection. So these are my references. So any questions will be highly appreciated. Thank you. Sir. So maximum safe dose, we use maximum dose in the literature. So in some literature, they use also the 20 milligram per kilogram as well. So we use 10 to 15 milligram of that dose. At 20 milligram, they also add less side effects as well. Any other questions will be? Yes, because it's a national and international conference, and our national level, there are only some centers which have this neuronavigation, cortical mapping, intraoperative. Even we don't have intraoperative ultrasound as well. So that's why in other centers where these gadgets are not available, so we can also, this is the way we can achieve the maximum safe resection for these miserable patients.
So Professor Chaudhary, obviously you must have reviewed the Professor Chaudhary, you must have also reviewed the literature. So in large series, has anybody yet shown a survival advantage in glioblastoma from operating with fluorophores? Both of them, ALA or fluorescein, to your knowledge? आपका नहीं literature review पे, I mean, just looking at the literature so far, published literature so far.
We'll look into aspect this as well, but practically it's educated everywhere that for the GBM, grassroots resection is the best way for having a longer life post-op cure and the better recovery of the patients. So the purpose was just to have the maximum resection of the tumor. And this can be achieved by two ways, either by the neuronavigation system based or by fluorescent guided system.
Oh, thank you so much.
Thank you, Dr. Mubashir. The next presenter is Dr. Wasim from Punjab Institute of Neurosciences, and he's going to talk about institutional experience of neuronavigation-assisted awake craniotomy using tractography and intraoperative neurophysiological monitoring for eloquent area brain tumors at Punjab Institute of Neurosciences, Lahore.
Assalamu alaikum and a very good morning, everyone. I am Dr. Wasim, representing Neurosurgical Unit 1 of Punjab Institute of Neurosciences, Lahore. And today I'm here to share with you our institutional experience of neuronavigation-assisted awake craniotomy using tractography and intraoperative neurophysiological monitoring for eloquent area brain tumors. So the basic purpose of the study was to evaluate the awake craniotomy using tractography and intraoperative neurophysiological monitoring for excising the eloquent area brain tumors in terms of the extent of resection and post-op neurological status. The study was a case series 1. It was conducted at Punjab Institute of Neurosciences, Lahore from November 2016 up till the March 2020. And it included 23 consecutive cases of awake craniotomy. Each case was assessed clinically before the surgery, immediately after the surgery, and at 1 month and 3 months after the surgery. Now, the most important inclusion criteria was that the patient must be having a parenchymal brain lesion in or adjacent to the eloquent area of the brain. Patient must be a cooperative one, and the age must be over 14 years. And all those patients who were uncooperative, had diminished level of consciousness, or profound dysphagia, or a problem of obstructive sleep apnea, were understandably excluded from the study. Now, it's a well-established fact in neurosurgery that the extent of tumor resection has a direct impact on patients' post-operative outcome, morbidity, and complications. Because of these obvious reasons, it has always been advocated to find a way to intraoperatively localize the key areas of language and motor function so that we could safely excise the lesion while preserving the neurology of the patient. The answer to this is awake craniotomy, intraoperative neurophysiological monitoring, and tractography. The combination of these techniques enable us to radically excise the lesion while preserving the neurology of the patient at the same time. Now, there are certain pre-op requirements before we proceed to the awake craniotomy. Firstly, we need the MRI images of the patient based on the neuronavigation protocol and diffusion tensor imaging. We also need the neuronavigation stealth station, the Inovid microelectrode recording machine, a microscope, accusa, and a well-trained anesthesia team. Now, this is the neurosurgical setup of for awake craniotomy. Here you can see the neuronavigation stealth station, the microelectrode recording machine, and the pre-op DTI images of the patient. As I've already said, the anesthesia management is very, very important for awake craniotomy. This is because the patient undergoes a transformation from sleep to the awake phase. This is also known as sleep-awake pattern of anesthesia. Now, previously, anesthetists used to give propofol or fentanyl to induce the sleep. But now, because of the better neurocognitive effects, dexmedetomidine is the preferred choice. Patient is put to sleep, LM is passed, scalp lock is applied, positioning is done, incision site is marked, neuronavigation registration is done, electrodes are applied on the contralateral side of the body, and craniotomy is done. Now, the next step is direct cortical stimulation. For this, the patient must be in the awake phase. And a bipolar stimulation is given to the certain area of the cortex while we monitor the contralateral side of the body for the movement, and the microelectrodes also recorded in the form of a biphasic response. Here you can see the bipolar stimulation being given and the electrodes recording it in the form of a biphasic response. So in this way, we map the motor area of the patient. Next step is the speech mapping. Again, the patient is in the awake phase. Pre-op language assessment has already been done and the patient is engaged in a conversation or is given a reading or counting task. and while we stimulate the language area of the patient, and the patient goes into sudden speech arrest. In this way, we map the speech area or language area of the patient. Now the next step is tumor resection. Resection begins farthest from the eloquent cortex, and we progressively move towards the eloquent cortex. And while performing the intraoperative neurophysiological monitoring, and on registering the slightest weakness, we stop the resection. So in this way, we are able to achieve the radical excision of the tumor safely and preserving the neurology of the patient at the same time. Now, these images are the examples of the tractography. Here you can see the relationship between the tumor and the precentral gyrus and the corticospinal tracts. Again, these images are just the pre-op images.
Please be quick.
Pre-op images, and just give us an idea about the route that we could use for the safe excision. And now, with the arrival of the real-time fiber tractography with the software called StealthWits, we are able to actually navigate these fiber tracts while performing the surgery. And this further enables us to safely excise the lesion. And with the addition of functional MRI into our arsenal, we have also tried to incorporate it as an adjunct to the awake craniotomy, and the results are quite outstanding. And we are further planning to incorporate functional MRI with the awake craniotomy. Now, this is just a case review, and this is one of the 23 cases that we have performed. These are the pre-op images of the patient. And in this video, you will see how we have done the speech mapping and the motor mapping. We are trying to communicate with the patient, but patient is unable to speak, so there is the speech arrest. This is how we map the language area of the patient. This is the motor mapping and the biphasic response. This is the biphasic response. And this is the bipolar stimulation being given. So now the resection began. And block excision achieved safely. So now coming to the results, out of 23 patients, 14 were male and 9 were female. The mean age was 35.5 years. Out of 23 patients, 11 had tumor in the premotor area, 5 in the prefrontal, 3 in the primary motor, and 2 each in the language and insular area. And preoperatively, 7 patients had neurological deficit. Immediately after the surgery, 7 patients had additional neurological deficit. And at 1 month after the surgery, only 5 patients had additional neurological deficit. And at 3 months after the surgery, only 2 patients remained with persistent neurological deficit. Radical excision was achieved in 17 patients and subtotal excision in 6 patients. Positive cortical mapping was achieved in 19, and in rest, there was a negative cortical mapping. This result is the summary of our results. And this is the histopathology. So we finally arrive at conclusion that although these are initial steps towards the excellence about awake craniotomy, tractography, and intraoperative neurophysiological monitoring, but we can successfully conclude that the combination of these techniques help us in radically excising the lesions safely, and while preventing us from adding to the neurological deficit of the patient. This is particularly important for the low-grade gliomas in young patients because the mean survival in these patients is very good. So if we can achieve the radical excision in these patients, then the awake craniotomy can work as a miracle for them. Thank you. Any questions?
So excellent work. Thank you very much. So I just want to ask a question, and then if I'm allowed, a quick comment. And my question is, Khalid, also subcortical mapping, bipolar stimulation, subcortical. I know you're doing cortex. I can see that. Were you doing subcortical as well? Is that part of your routine? Just cortical, not subcortical. Because that seems to be, not that I've done it, but that seems to be the thing that people find most helpful now, that you have this thing. Khalid, I just want to make one comment, and that is that I think, of course, I can see that the trend in improved safety of resections of low-grade gliomas when you're monitoring in the awake state the patient, and then you've got the added advantage, which I think is excellent, of doing the MER recordings. So, and that's excellent. So, but I just want to make, the comment I want to make is, I'm really convinced myself that technology will slowly take us to the point where you don't have to have the patient asleep. And you know, I watched your video very carefully, and I could hear Khalid in the background trying to pacify the patient, because it's not an easy thing to go through. He was saying, abhi khatam ho gaya, abhi khatam ho gaya. It's a difficult thing to go through, and although it's a huge advantage right now in the current state of technology in maximum resection of low-grade glioma, and if I had a low-grade glioma, I would want an awake craniotomy to maximize the thing. But I'm making the point to you that, for instance, transcranial magnetic stimulation, motor stimulation, is when you marry that with neuronavigation, is a terrific advance. And I think over time, the technology will take us to the point where we don't have to have them awake.
I think perhaps AKU is just doing the awake craniotomy with the patient monitoring, but we have also complemented with the MER. And what, yeah, I think what I anticipate is, and our next results we're going to publish is what's the correlation of the MERs and then the deficit. It not always correlates, but in most of the patient it does. And it's really, really helpful. And we are now excising tumor more and more radically in the eloquent area with that technique, with the combined technique. And I'm very thankful to my great team. We don't have neurophysiologists. It's the passion and my team of neurosurgeons who's dedicated for awake craniotomy and monitoring, who would do for DBS, who would do for awake craniotomy, who would do for spinal cord monitoring and everything. And this is the neurosurgeons, nobody else.
Thank you.
Thank you, Dr. Wasim. Now the next presentation is by Dr. Shahzaib Tasdeeq from King Edward Medical University, and his topic is far lateral transcondylar approach for anterior foramen magnum lesions.
Bismillahirrahmanirrahim. My name is Dr. Shahzaib Tasdeeq. I'm consultant neurosurgeon, Mayo Hospital, Lahore. Welcome to all of you. The topic of my presentation is far lateral transcondylar approach for anterior foramen magnum lesions. I won't go in the details, just a brief review. Anterior foramen magnum lesions, anterior foramen magnum and craniocervical junction is a site for various neoplastic lesions such as meningioma, chordoma, neurofibroma, epidermoid, and vertebral artery aneurysms. Initially, surgical treatment of these pathologies were associated with major complications, but with the invent of far lateral approach, you can safely excise the lesion of this area. The objective of our study is to determine the neurological outcome in patients with anterior foramen magnum lesions treated surgically through far lateral approach. A descriptive case series study was conducted at Department of Neurosurgery. Six patients were selected with non-probability purposive sampling and followed for a period of 6 months. Patients with anterior foramen magnum lesions in between age of 12 to 65 were selected, and the patients who were unfit for general anesthesia due to the comorbid were excluded from the study. The majority of the patients were female, that is about 2/3 of the population of our sample size. Now the presentation. 3 out of 6 patients were presented with quadriparesis. 2 out of 6 patients were presented with neck pain and 1 with lower cranial nerve palsy. This is the MRI of one of our patients showing lesion in the craniocervical junction. extending to the level of C2. And in axial images, you can see that the lesion is extending out of the neural foramina in the extraspinal space. The procedure was for lateral transcondylar approach and excision of the lesion after consent and complete work of the patients. This is how we placed our patient in lateral modified park bench position. Mayfield was flexed and head was rotated, flexed, and laterally bent so that the mastoid process comes at the highest point. This is the incision. We used a retroauricular curvilinear incision starting 4 to 5 centimeter above and behind the pinna, and continued inferiorly to the neck over the posterior border of the sternocleidomastoid muscle to the level of C3 or C4. So muscle dissection and exposure of the vertebral artery was done. Muscle was incised in a single layer. Exposure of and control of extradural vertebral artery was achieved by identifying the vertebral artery from its exit at the C2 foramen transversarium between C2 and C1, or from exit from the C1 foramina and from over the C1 lateral mass vertebral groove where it enters the dura mater. This is the bony exposure. Lateral suboccipital craniectomy was performed, followed by hemilaminectomy of C1. The extent of suboccipital craniectomy medially and superiorly depends upon the extent of the lesion. The posterior 30 to 40% of the condyle was drilled extradurally. This helped in angle exposure and greater visualization of the ventral and ventrolateral aspect of the craniocervical junction. This is how we opened the dura. It's a linear incision showing, you can see that on the cranial side, the cerebral folia is there, and on the caudal side, the tumor is there, but it is engulfing, or the arachnoid is covering the tumor. Now, after opening the arachnoid, the anteriorly placed tumor can be seen with the red arrow, and the yellow arrow, you can see the C1 nerve root, and with the green arrow, you can see the spinal accessory nerve. This is the image taken after the complete resection of the tumor. Now, the case summary. As I have told you, a majority of the patients were female. Average age was around 50. And the complication we...
Last minute left, Dr. Saab. Please be quick.
The complication we noticed was CSF leak in one patient, and 3 out of 6 patients were proven to be meningioma, 2 patients with neurofibroma, and 1 with chordoma. Now the results. Majority of patients were middle-aged female. Most common presenting symptom was quadriparesis. Majority of patients proven to be having meningioma. All the patients operated through far lateral transcondylar approach, improved neurologically, and symptom subsides. The only postoperative complication encountered was CSF leak from wound in 1 case. Concluding my study, far lateral transcondylar approach is an effective neurosurgical procedure for treating anteriorly placed foramen magnum tumors with significant reduction in morbidity of the miserable patients. Thank you.
So one quick question, Dr. Saab, your chordoma patient, did you know beforehand that this was a chordoma?
No, we're not expecting this.
Right. Otherwise, you would have taken a different approach.
Yeah.
Yeah.
Thank you, Dr. Shahzeb. Thank you. Now the next presenter is from Aga Khan University Hospital, Dr. Saqib Kamran Bakshi, and the title is Awake Craniotomy for Excision of Brain Tumors, First 200 Cases from Pakistan.
Assalamu alaikum. So I'm thankful to my colleague from Punjab. He has already mentioned all the necessary adjuncts and details, so I can easily skip the intro. My work has been supervised by Dr. Athar Inam, and I am currently working as an instructor at the Aga Khan University Hospital. So as has already been mentioned, that awake craniotomy is an important technique which has shown to improve the neurological as well as surgical outcomes of brain tumor patients. I had a small video as well, but we can skip this. So I'll come straight to our study. The primary objective of this study was to assess the functional outcome of the first 200 cases of awake craniotomy performed at our center for excision of brain tumors. And our secondary objective was to compare the functional outcomes after awake craniotomy with cases which were performed under general anesthesia. So this was a retrospective case control study, and we included patients during a period of 5 years from November 2015, when we first did our awake craniotomy case, till November 2020. 200 cases of awake craniotomy and 100 cases of brain tumor resection under general anesthesia during the same time period were included in the study. And all these cases were performed at our center. So we had obtained ethical exemption because it was a retrospective review, and we used Karnofsky performance scale to assess the functional outcome of the patients preoperatively as well as on the last follow-up. So patients who had undergone craniotomy for tumor resection under scalp block, irrespective of their age or gender, during the 5-year period were included in the cases. And the first 200 cases of brain tumors resected under general anesthesia during the same time period were included as controls. So we also performed statistical analysis to assess any correlation. So out of 200 awake craniotomy cases, 79% were males and 21% were females, whereas in the general anesthesia series, 66% patients were male. The mean age in awake craniotomy patients was slightly less as compared to the general anesthesia patients. An important finding was that the mean hospital stay in patients who had awake craniotomy was statistically significantly less as compared to those patients who had undergone surgery under general anesthesia. And the mean follow-up in both the series were almost comparable. So the most common presenting symptoms in awake craniotomy patients was seizures, because most of these were lower grade lesions, whereas in general anesthesia case, among the general anesthesia cases, motor deficits, headache, and seizures, they were all almost comparable presenting symptoms. The most common location was frontal lobe in both the arms. And the most common lesion, the histopathological diagnosis in the awake craniotomy cohort was oligodendroglioma, whereas among the patients who had undergone craniotomy under general anesthesia, the most common one was astrocytoma, and most of these patients were actually glioblastoma patients. We compared the extent of surgical resection with the technique of anesthesia, and a common notion is that if when we perform awake craniotomy, our tendency is more towards safety and less focus towards extent of resection. However, we found that in most of our awake craniotomy patients, we had achieved gross total resection. And this was in contrast to the patients who had undergone surgery under general anesthesia, and this was statistically significant as well. Regarding the change in functional status, there was significantly improved outcome in terms of Karnofsky score in the patients who had undergone surgery under awake craniotomy. Now, out of 200 cases, 31 of our patients had new intraoperative neurological deficits during surgery. But at last follow-up, only 4.5% of these patients had persistent deficits. So more than half of these patients had only temporary weaknesses which occurred during surgery, and they had recovered from them by the time of last follow-up. In contrast, general anesthesia patients had more persistent neurological deficits. Same is true for the intraoperative speech deficits as well as intraoperative worsening of motor power. Most of the patients, more than 50% of the patients of awake craniotomy had intraoperative, of those who had intraoperative deficits, more than 50% of those recovered by last follow-up. This is a very important slide. It shows that in the awake craniotomy patients, the preoperative KPS and postoperative KPS had a statistically significant difference. However, in the patients in general anesthesia group, the difference was not significant. So awake craniotomy definitely leads to better functional outcome. The limitations of the study is retrospective study design, and the two study groups were unequal. We can conclude that awake craniotomy is a safe tool for resection of brain tumors, and most complications which arise during surgery recover by the time of last follow-up. There is shorter hospital stay in awake craniotomy patients, and there is better chance of improved functional outcome in these patients as well. There is a better extent of resection in patients undergoing awake craniotomy as compared to those undergoing general anesthesia. Thank you. So, any questions?
What was the numbers that crossed over? In other words, who went from awake, or rather regional anesthesia to general anesthesia?
So none of our patients had to switch from awake to general anesthesia during surgery. However, we did not assess those patients who were planned for awake anesthesia, and before the start of procedure, they were switched towards general anesthesia because of anxiety or other factors.
And that number, any idea offhand?
But that I have not specifically assessed, but that is not a significantly large number. Thank you.
Thank you, Dr. Saqib. The next presentation is by Dr. Zain Saleh, Punjab Institute of Neurosciences, Lahore. And his presentation is about outcome of interhemispheric transcallosal approach for resection of anterior third ventricle lesion in terms of excision and post-operative complications, a case series of 15 cases.
Assalamu alaikum, ladies and gentlemen. I am Dr. Zain Saleh, resident neurosurgery unit 1 from Punjab Institute of Neurosciences, Lahore. And today I'll be discussing the outcome of interhemispheric transcallosal approach for the resectioning of anterior third ventricular lesions, and we'll discuss the results in terms of excision and postoperative complications. Now, the objective of the study to determine the efficacy and safety of interhemispheric transcallosal approach in the resectioning of solid anterior third ventricular lesions with its subchoroidal and transvelum interpositum modifications in terms of excision and postoperative complications. For that purpose, we did retrospective analysis of the data. The inclusion criteria included solid colloid cysts that were hyper on CT and hypo-intense on T2 weighted MRI images, suggesting that the lesion was solid. And other patients presented with anterior third ventricular lesions who already had an ECSF diversion procedure performed. We excluded the patients who had third ventricular lesions who were hypo-dense on CT and hyperintensity to MRI, suggesting that the colloid cyst or the third ventricular lesion was soft in nature. Now, briefly discussing the history, Walter Dendy pioneered the interhemispheric transcallosal approach in the 1920s and later reported a series of third ventricular tumors in 1933. And did an anatomical study of the choroid fissure and discussed the supra and the subchoroidal roots. Now, what are third ventricular lesions? The third ventricular lesions account for approximately 2% of all the brain tumors and usually present with obstructive hydrocephalus requiring emergency intervention. Colloid cysts are the most common in this group, and we describe our experience with the subchoroidal transvelum interpositum modification of this approach in this study. Now, this is a diagram showing the different routes. We employed the subchoroidal transvelum interpositum approach at the right. Now, what are the advantages? It is the best technique at present to offer complete excision of benign lesions like colloid cysts and provide direct access to the third ventricle, avoids cortical incision, and does not need ventricular dilatation. But there's a disadvantage that there is a risk of ornithal injury and thalamic infarction. Comparing it to the endoscopic approach, the transcallosal approach provides access to the both walls of the lateral ventricles and provides proper access to the roof where the colloid cysts are usually attached, which is deficient in endoscopic approach. Now, a quick rundown of the operative technique. The patient is positioned supine, the head is flexed at 30 degrees. Horseshoe incision is sited 2/3 anterior to the coronal suture. This is the operative setup. This is a nice little operative video of detailing the steps. Here you can see the pericallosal vessels beneath. Can we please switch on the volume? The mean length of callosotomy in our study was 1.2 centimeters and varied from 1 to 1.8 centimeter. Here now we'll be going through the subchoroidal and transfilamentary positum route. Now the colloid cyst is being removed, as you can see. We usually perform a pelvicotomy at the end of the procedure. Here you can see a scale measuring the length of the callosotomy. That was 1.2 centimeters in this case, and that was also our average. Now moving on to a case review included in this series. A 36-year-old lady presented by outdoor with persistent headaches and blurring of vision. On examination, she had bilateral papilledema. On fundoscopy, the rest of neurological examination was unremarkable. This was a pre-operative CT. There was a well-defined cystic hyperdense lesion, suggesting of solid colloid cyst. That was ISO on T1 and hypo on T2. Post-operatively, the lady had relief of headaches and blurring of vision, and histopathology confirmed the diagnosis of colloid cyst, and she was subsequently discharged at 6th post-operative day. A quick rundown of the results now. The median age in our study was 24 years, and most of them were male patients. 12 patients had no major post-operative complications. 1 each developed meningitis, seizures, and disconnection syndrome. The mean length of callosotomy in our study was 1.2 centimeters, and the major histopathology was solid colloid cysts. 2 patients had central neurocytoma and 1 ependymoma. The mean duration of follow-up was 3 years, and the mean hospital stay was 6 days. Regarding the extent of excision, gross total excision was achieved in 10 cases, and subtotal resection was achieved in 4 cases, and only debulking was possible in 1 case. There was no significant association between histopathology and post-operative complications. Now to discuss, the interhemispheric approach to the third ventricle is the preferred technique, especially in young, healthy patients, where the goal is to perform complete excision of the lesion and has minimum morbidity and mortality in expert hands. With its subchoroidal modification, it offers wider access to the anterior and even the middle of the third ventricle, aiding the goal of complete excision. Now, this approach spares the cortical incision, and however, it is a challenging technique for young surgeons to perform within the narrow corridors of interhemispheric route. To conclude, the interhemispheric transcallosal approach with small callosotomy is safe and is superior to the endoscopic approach for the resectioning of solid colloid cysts and other anterior third ventricular lesions and is not dependent on the ventricular size. Thank you. Any questions, please?
Thank you very much for the nice talk. I just want to ask a question about one of the complications in your case, the disconnection syndrome, which you encountered in one of your patients. Although the length of collosotomy was 1.2 centimeter, which is far away to cause the morbidity. Just, I'm curious, what was, do you think, the cause of this disconnection in your?
So actually, the mean length of callosotomy was 1.2 centimeters. The maximum was 1.8 centimeter in one case. But the average mean majority of the cases was 1.2 centimeters.
1.8 is still far away from causing this type of morbidity.
We didn't analyze in that way. I'll leave it to the experts.
I think there was a one patient who had a problem, but that was temporary, and that was an elderly patient. But it was noticed in the hospital stay, but this patient never reported back with a permanent deficit. And I do understand that it should not happen because for epilepsy surgery, you can do anterior two-third callosotomy and you can stage complete callosotomy even without causing disconnection syndrome.
Thank you.
I think that I think your music was Claire de Lune by Debussy. Is that correct?
Ocean 11, yeah.
Okay, fine. Thank you.
Yes, sir.
I just want to make the
one
point,
of my favorites.
I just want to make the point that we had a meeting in Karachi of PSN. I forget now, maybe 1993 or something. We had it at Regent Plaza. And at that time, I presented my first series of colloid cysts done endoscopically. And since then, I honestly cannot remember a case where in the absence of drained ventricle, so we're obviously talking, you have to have the access of a large ventricular system. Honestly cannot remember where I've said, oh, I can't take this out and I have to convert to a craniotomy. In other words, for an expert endoscopist that there is in your department, I'm sure that if they really wanted to do it endoscopically as a first thing, they would probably be successful in 100% cases.
Yeah, may I just comment myself? There are two reasons. One is, as you know, that colitis is present in emergency, and in emergency, the consultant cover is not available. So our senior registrar and the senior residents, they tend to do the shunts that goes across and drains the both ventricles. So left with small ventricles and a colloid cyst. So we thought that is a very good indication. And the second is, even in this case, you would see that the colloid cyst was pretty firm and you could not suck it. You really have to separate it and you have to use the pituitary rongeurs for that. And I personally feel that removing colloid cyst, which is semi-solid, it's a bit difficult if you want to excise it completely. You can do, but there is always some part that is left behind and it bothers the young patient for the rest of life. So we have found transcallosal, to be honest, is one of my other passions to do the transcallosal surgery, and not from colloid, but sometimes you do get other third ventricular tumors.
And I don't know whether these gentlemen want to comment on their conversion rate or their inability to take it out endoscopically.
Thank you very much. Up till now, I must say, out of 60, 70 cases which I have done through endoscope, I have converted only one case from endoscope to conventional transcortical. And the rest of the cases, I must say I succeeded. But before going to decide either to operate this patient endoscopically or transcortically, because I have never operated any case of colloid cyst transcallosally, only 2 cases we operated transcallosally for one case was glioma, which was later on reported as glioblastoma. We thought it may be low-grade lesion. And in the rest of the cases, we first decide either to go transcortically or endoscopically. So if the cyst is small, you see, and if it is hard, and if anatomically it is difficult, and the ventricle are dilated, so my first thinking will be probably that I go transcortically. If the cyst seems to be, you see, cystic, and it is lying right in the center, not eccentrically, and when it is lying in the posterior part more, in which I can add the ETV along with the endoscopic excision as well. So preferably I go through endoscope, but I have never operated any colloid transcallosally. The conversion rate was only in 2 cases I have converted into.
I'm totally agree with Dr. Khalid that sometimes the colloids is so thick, the content is so thick, you cannot you cannot remove it endoscopically. Recently, we went from endoscope and we tried to suck the colloids material, but even that was so thick, so bleeding was started, and we have to just quit the procedure, and we came out. Luckily, the patient is good with the extraventricular drain. Now we have removed, and now we will switch over to the transcallosal approach. So this is very right. You cannot assess from the MRI or CT which colloids you have to go from the endoscopically, and which you can use from the transcallosal.
If it is a jet black on T2, I am 90% sure that it's going to be hard. Jet black. It has to be jet black. And that's the Henry Schroeder, you know, he taught me. Just jet black. And there was only one conversion in a doctor. Otherwise, we don't convert really. We work so much on the images and sequences and other things. And there's another sequence actually, it's called the STAIR or something like that. I have just forgotten. That's more helpful in finding the contents of the colloids, which we don't do in Pakistan here. So you should really do in this era complete workup so that you know what are you dealing with and what approach you have to. Unless there is a bleeding or something else, you know, you should really not be converting on the basis of contents. You should know the contents before. And pituitary content, pituitary consistency, you can't tell by imaging, but the colloid you can tell. That's the benefit of the good imaging in the colloid. And it's almost standard actually. Still in America and Europe, a lot of people don't remove colloids endoscopically. They do either transcallosal or transcortical. There's a for few subset of patients.
Initially, people used to do this colloid cyst microscopically. Then there is a trend of endoscopically. And now again, there is a paradigm shift of this procedure, the treatment of this disease, the colloid cyst, to microscopically. And there are a couple of RCTs available in the internet where you can see there are a lot of benefits of doing these procedures microscopically, especially transcallosally, and especially in those cases where the cyst contents are solid rather than liquid. Thank you.
I think we're just running late, so we can have this discussion at coffee. Thank you.
Thank you so much.
Thank you, Dr. Zen. So our session now ends here. I would request everyone to please move to the exhibition area for a short tea break of 10 minutes. Meanwhile, the participants of oral presentation part 2 are requested to submit their presentations soon. Thank you.
Oh, dapat kira Australia beja.
Awesome. लियाकत का है ना That's tough. सिर्फ कनेक्टिविटी का इशू है बाकी आराम से
बस बस बस
डॉक्टर शहीद
डॉक्टर शाहिद
डॉक्टर शाहिद जी मौजूद है सर डॉक्टर शाहिद
की
सर मौजूद
ये
ठीक है यही
इसके बाद
मौजूद
में इंट्रोड्यूस करूंगा मैं आऊंगा
ठीक यहाँ मौजूद है सर नो इशू
एनिडेस कर दिया मेरी जिंदगी सुकून में आ जाएगी यार ये
सर एनी डेस्क का कोई इशू है यहाँ पे माइक माइक तो बंद कर दिया
अभी लास्ट आपने किसी को दिया था तो स्विच ऑफ था वो आप स्विच कर दे
समझ रहे होंगे कि ऑफ माइक
Welcome back. We are now going to resume our session with Shahid Ahmed's session. For chairing this session, I would like to call upon stage Dr. Sattar Hashim, the co-chairperson, Dr. Shahid Ayub, and moderator, Dr. Abdul Munam. I would request Dr. Sattar Hashim to come and say a few words.
Bismillahir Rahmanir Rahim. First of all, I'm thankful to Dr. Salman to allow me to say a few words. If for youngers, if we don't remember our legends, I think then the time will pass. As Boyle said, the service to humanity is service to God. Let the love and light of the kingdom radiate through you until all who look upon you shall be illuminated by its reflection. This is the one pick with Dr. Shahid as a coach, as a chairman. Again, friendly with Dr. Mumtaz. Again, he was born in 1955 in Karachi. He received his early education from Happy Home High School, Karachi, and FSC with first division in 1973 from Government National College. He got admitted in Janka Medical College and was confirmed degree in 1980. He completed his house job and 2-year training of general surgery from Kalsum Balika Hospital, Karachi. He was appointed as a medical officer in JPMC in Neurosurgery Department and cleared his FCPS Part 2 in Neurosurgery. He then was upgraded as a senior registrar and then served JPMC as assistant professor in 2000 till 2006. He left JPMC and was appointed as a professor and head of Department of Neurosurgery in Abbasi Shaheed Hospital in 2006. He made great contribution in establishing Neurosurgery Department in Abbasi Shaheed Hospital and offered his services till 2015. He also served CPSP as an examiner. He has a lot of publications and professional profile. He worked unanimously and selflessly and considered his life devoted for his noble profession. He thought highly educated. Though highly educated, intellectual, and highly civilized, but was always doomed to earth. He considered patients' miseries as his miseries, their sorrows as his sorrows. He believed in humanity and shadowed it by his deeds. He was much learned toward the profession that even served patients before his death. As this is in some workshop and also with colleagues, you can see here a workshop with Professor Atul Goel, and he with his mentor and friend, Mr. Hamidullah, Dr. Hamidullah Buzdar, and again, he was a presenter, first presenter in the first national conference. You can see Professor Bashir and also Professor Raja and also his friends. With other friends and with his mentor, Professor Aish Bhatti. May Allah Almighty rest his soul in peace in the part of paradise in heaven. He was my student first, then colleague, and then friend. And I have got all prayers for him. Last night, I attended the marriage of his elder daughter, and he has grown his children to the higher education level, and I pray for him. Thank you very much for patience.
Thank you, Dr. Sattar. Now, the first talk of this session is by Professor Athar Inam, and he'll be connecting with us through Zoom, and he's going to talk about awake craniotomy.
Okay. Okay. All right. So once again, thank you very much for this opportunity. I'm sorry I could not come there physically because I had some other academic session that I had to take care of, which was planned a few months ago. This lecture is dedicated to Professor Shahid Ahmed, a thorough gentleman, and I agree with Dr. Professor Sattar that he was a very humble person and a very talented person. Um, we will always remember him with fondness and cherished memories. No question about it. So I will start with this slide first, and
بسم الله الرحمن الرحيم هو الله الذي لا إله إلا هو الرحمن الرحيم الملك القدوس السلام.
So we see in Facebook and we see in other places a lot of videos about how somebody is singing, somebody is saying things. There has not been any recording that I'm aware of awake craniotomy, somebody reciting Holy Quran. I can tell you that recitation of Holy Quran during the awake craniotomy gives me a lot of confidence, and it's a really a good feeling that you have this picture was obviously with his permission. Quickly going over disclosures, none, no conflict of interest. So I have only 10 minutes, but I will try to cover the main things in this talk. It's not about the surface of the brain only, it's all about the cortex. But then whatever we do for resection of brain tumor, we try to bring in as much technology as possible. It turns out that technology will not help you completely. You have to learn something about techniques as well. So whether it's functional MRI, tractography, or exoscopy, or endoscopy, or microscopy, or neuronavigation, or robotics, or neuronavigation, or 5-ALA, and all that, none of those really help a whole lot as much as awake craniotomy does. It is with the awake craniotomy that one can actually resect safely and confidently to the margins of the tumor. For example, if you look in this one, this was a low-grade glioma with getting all the way to the motor cortex area. And here is on the left side with the speech area with the arcuate fasciculus going right around it, and still you can resect it. Gross total resection can be done on this thing if you monitor the patient carefully and confidently. And here is the post-op image of that patient. This is exactly where the area where we talk about Broca's area, and that has been removed. So the importance of awake craniotomy is actually more than that. I see it from the perspective of global neuro-oncology. We talked about gliadal wafers. We talked about 5-ALA, $5,000 price here, $11,000 price here. We talked about proton beam radiation and things like that. But then a simple technique of awake craniotomy, which does not cost you extra, can save a lot of trouble. This is a patient with a GBM with the mass deep inside, and instead of mapping the surface, which would not have helped a whole lot, the only help that I got in this case was to find the right spot, the trajectory to get to the tumor. But the main benefit was subcortical mapping in this case. And if you look at it, the internal capsule is right next to it. And here we see a complete resection of the glioblastoma. So from the global perspective, I see that subcortical mapping with simple electrode is enough. We don't even need a tractography. We don't need high-end MRI when we talk about resource limitations. Here are about 200 cases that we have done since I started this in November 1995. And we did a comparative analysis of those 200 cases, and Dr. Saqib Bakshi has already probably presented it in the oral presentation in a different hall. This was a 200 cases consecutive compared to 100 with GA, awake craniotomy GA, and they were all comparable groups. There was slight difference in histopathology. If you notice over here, the astrocytoma was less and the oligodendroglioma was more in the awake craniotomy, whereas in the general anesthesia, the oligodendroglioma was less than the astrocytoma. That is depends on how they present. They come through the ER or they come through a clinic. But if you look at the extent of resection, whether we use awake craniotomy, which is gray, awake craniotomy, which is blue, and general anesthesia, which is gray, don't go by this. These are the numbers, but look at the percentages: 41%, 32%. So gross total resection was definitely better achieved in the awake craniotomy. If you look at the pre-op KPS and the post-op KPS, again, in those 200 cases, there was no difference between the patient that underwent general anesthesia or had awake craniotomy, but then the improvement in the KPS was significant in those patients who underwent awake craniotomy. And it's not that we don't do good work. When we compare our work to a North American institution, this was University of Kentucky. If you look at it, our work is actually shows over here. This is the overall survival, which is blue, which is this line, and the University of Kentucky, the overall survival, which is this line. There's definitely improvement and progression-free survival, and the gross total resection was better with the techniques used over here. Although there's little difference in pathology, and the difference persists, however, somewhat even if you compare GBM to GBM. And then the awake craniotomy doesn't have to be used only for brain tumors. I've used several in the AVM resection also, and that's what I find actually to be most useful. Here is a patient with the left, young patient with the left parietal AVM right at the angular supramarginal gyrus over here, fed by the MCA and draining into the deep and superficial veins, both suprasagittal sinus and the transverse sinus. And this is the AP view of that patient. On the you can see it's all fed by the MCA mainly, and training. And this is a really fast forward and intraoperative image video. Of course, I can't go this fast, but it has been fast forwarded. So this was done with the monitoring of the patient. She was awake and constantly watched it. Speech was monitored, and we were able to remove this whole AVM without any deficit. But that's not the only thing. The problem was that there was a residual also. And this is where really awake craniotomy helped a lot. You can clip that vessel and monitor the patient's response. So we waited for about 5 to 10 minutes, and there was no deterioration of her speech and everything. And at that point, we decided to remove the clip and take that part of the AVM also, which was a residual. If this was not so, we would have been really very anxious whether we can remove that part or not in the end, because that artery was supplying the functional area also. And this is the post-op MRI, which shows total resection of the AVM in the lateral view, and in the AP view, total resection of AVM, and the patient remained totally intact. So thank you very much for letting me present the awake craniotomy cases. All kind of we're doing awake craniotomy for extraaxial lesions also, and that is also being presented by Dr. Saqib Bakshi, which is again probably one of the highest series in the world that we have of the extraaxial lesions presented. And once again, thank you very much for listening to my talk. You're mute. I can't hear you here. I'm unable to hear anyone here. The conference is mute. Can somebody turn it on, please?
Talk. And there's a certain amount of hammer and nail situation here. If you listen to people like Mitch Berger in San Francisco, and if you listen to people like Defoe in Montpellier, to them there is no question that this is a significant advance in neuro-oncology. And there is also no doubt that in the way that you do things, for instance, I just want to talk a little bit about something, Khalid, you haven't talked about in your presentation, and Athar hasn't talked about specifically, and that is insular gliomas. And insular gliomas, as the surgery has evolved, there are two ways of doing it. One is that you open up the sylvian fissure widely, work your way up to the superior insular sulcus and the superior insular sulculus, and define the thing, and then start working down into the tumor. That's one way of doing it. And incidentally, that's the way I've been doing it from the beginning. The second way, which a lot of people find, I've done it once, and I can see why they like it. Because what you can do is go through the opercular, go through the cortex above and below the sylvian fissure. And then what you do is you join your two resection areas below the sylvian fissure, below the middle cerebral vessels, avoiding, of course, the perforators. So to do that on the left side is impossible without a wake. It's just impossible. That would be foolhardy. Nobody would do that. So there are some things in which, of course, it's absolutely critical. But if you want to work around it, then there are other ways of doing stuff that you can achieve the same results with a non-awake, asleep. The point that I made this morning, and I just want to reiterate that, is that nobody has shown that awake improves survival. However, Athar's presentation, Saqib's presentation, Khalid's presentation didn't present the data in detail enough to make that conclusion, but what they're all showing is that in awake, they're able to do more. And Khalid, certainly I can tell you a number of times when the patient has woken up and he's without deficit, I think to myself, yaar, I wish I had done a little more. Main piche hat gaya, I backed off, and I wish I had done a little more, And that's the thing, that's the big thing for awake. And that's why I want to re-mention the technique. So people have now developed transcranial magnetic stimulation. And if you can marry your TM stimulation to neuro navigation, so that the stimulation is navigated, and then you're doing EMG monitoring. If you can do that, virtually all these things you can do, except of course speech, but all these things you can do in the asleep state. And I think that eventually with improved bold imaging, this is going to take us there. Saad, do you have any response?
Dr. Jama, yeah, here. So my experience with awake insular glioma, just 2 patients. And the first one I did, Dr. Jama here. Okay. So Dr. Jama, my experience with awake insular gliomas are just 2 patients. And the first one that I did was a transsylvian, as you said. And while doing that approach, I found out that even blood vessels has pain sensation. So when we were doing that transfilling approach and we were manipulating the vessels, the patient was feeling pain. And that's one of the reasons people like Defoe talk about transopercular approach more, because that's the whole idea of doing it awake. I mean, I know you do it through transsylvian approach, but when you're doing it awake, you have this liberty of going through the operculum, mapping that area. And I think the next time if I have to do it, I will shift from trans, because while doing it, the patient was in so much pain that we actually had to dose him off. So my experience with transsylvian versus transoperculum, one of the reasons I would go towards transopercular is because of the pain sensation associated with blood vessels. Your comment on it, Dr. Jama?
So there's no doubt that patients appreciate blood vessel pain. There's no question about that. But it's really a question of whether you feel opercular gives you a better shot at getting the undersurface of the medial surface, not undersurface, the medial surface of the insular glioma. But the fact of the matter is, awake craniotomy is here to stay. But you know, I just want to, Khalid is very interested in this discussion, and Khalid will bear me out, that if you look at the DBS literature, what started off is that you have to have the patient awake to do MERs and do the recording. It's slowly drifting away, and more people are reporting their experience with doing implantation of DBS for Parkinson's from start to finish with the patient asleep, but with some kind of intraoperative monitoring or immediate post-operative imaging. And so I think that the technology may allow us to move away towards greater patient comfort. But until that time comes, I think it's a great question.
Dr. Jamal, just one more point. Like Dr. Khalid mentioned in his presentation, that they start with the eloquent cortex first. Now you have this option that you can start with the eloquent cortex, but if you, while doing it, you can have a deficit just right at the start of the surgery, and you may have to leave the tumor behind. On the other hand, you can start with the non-eloquent tumor, but by doing that, the patient will get tired. So what is your say on this, that you, while doing awake?
You want to so I think that like if it was speech, I think that you need to define the speech area first up, because that's the most important thing you have to do. And once you've defined that eloquence, then you can go and look for the margins of your resection and then try and work out whether there's this thing. And then what Khalid showed in his presentation, and that's, I think, what Athar was trying to show in his presentation, and that's important, is that if you really want to get aggressive resections, more than the cortical mapping, you need to have subcortical white matter mapping, because that's where you get into a residual tumor, and that's also where you get into deficits. So we need to have the ability to do subcortical mapping. But I just want to end my comment, and I think we've discussed this. I just want to end my comment by saying, certainly for all the young people who are doing tumor surgery, they must acquire as part of their armamentarium a cortical stimulator and bipolar electrodes for subcortical mapping. I think that's essential.
Yeah,
I would
just like to.
Time is over, and only my request is that what we know that it's beneficial for the selective cases, but as we are living in the same city, and I'm listening from patients, patient has got glioma or something, pathology on the right side, and it's a non-eloquent area like temporal region. Patients saying that I have been asked for awake craniotomy. So I think that from all the advocates of this awake surgery, I am going to ask, is there any benefit in such cases also? When you are doing a awake craniotomy in a non-eloquent areas, is it beneficial?
No, you should not be doing. You should not be doing awake craniotomy in non-eloquent areas. And also, I was just about to make the comments that we select the patient for awake craniotomy only on the motor strip. Anything that is in front or behind the motor strip, or it's a pure temporal thing, we don't do awake craniotomies, because the monitoring, it's very uneasy for the patient. It takes a long time for doing MERs and doing stimulation and things like. That's why we haven't done any insular gliomas as a part of the awake craniotomy, because insular glioma are very badly managed gliomas in this country, and they usually present with very large size. If it's a predominant temporal component like 90%, we just do the standard temporal lobectomy, identifying the MCAs and excising it. But if I have to follow, I follow the Professor Juma's technique of operculus technique, when you go above suprasylvian and infrasylvian, and you define and you join underneath the MCA. But the problem is on the dominant side. it is not possible to do awake craniotomy and monitoring in 4 or 5 hour surgery. It has to be a short surgery. And also, I think what we do is we do sleep awake and sleep craniotomy. It's not pure. So once we put the patient to sleep with the laryngeal mask, and once the craniotomy has been done and dura has been opened, the patient is ready to respond to you. And once we are done with it, then the patient is put to sleep as well. That's also one of the other modifications in which you gain the benefit of awake craniotomy in terms of the monitoring, and then you gain the benefit of being a painless and patient-friendly when they put the patient to sleep. Thank you.
Thank you very much. Thank you, Manoj. We are
Sir, I would like to ask experts while doing awake craniotomy, do you find the language area almost all the times at the Broca's area, or it is shifted somewhere else? Why I'm asking this is because awake craniotomy in a non-eloquent brain may be useful to find the language area, sir, which is not always restricted.
total resection, 67 versus 48%. Visual improvement is also more in endoscopic surgery. When you compare endoscopic endonasal with microscopic transfenoidal, the outcomes are similar. Though CSF leak is more in endoscopic surgery, transcranial surgery obviously had more risk of seizures. So this is the most recent published case series and with the highest number of patients. So this was published by our Korean friends, 182 patients. They classified their tumor into intracellular, intra and supracellular, and third ventricle extension. And they had gross total or near total resection in almost all of the patients. So gross total was 86% and near total was 20, so showing that they underwent radical resection. So the new onset hyperpatriotism occurred in about 50% of patients, and a new onset diabetes was there in 26.4 patients. There was visual improvement in 110 patients out of 182 patients. According to them, for intra-supracellular lesions and supracellular tumors, patient in the endoscopic endonasal approach has higher gross total resection, lower incidence of hyperpatriotism, and better visual outcomes. Tumor recurrence was 6.6 group. Now, if you compare outcomes of craniopharyngioma surgery, so this is another review. It includes 540 patients. Out of it, 130 only underwent biopsy and radiation. Follow-up was about 54 months. So their overall new endocrinopathy for all patients undergoing surgical resection was 37%. So according to them, if patient received gross total resection, he has about 2.5 times the rate of at least developing one hormonal issues. When you compare that with subtotal resection or subtotal and radiation, and patients who undergo radiation has a more bad visual outcome when you compare to those who have not received. So according to them, aggressive surgical resection had led to some, the general goal of gross total resection in all cases might lead to unacceptable rate of endocrinological issues, behavioral issues. So the preoperative evaluation, we all know, has to be a full endocrinological workup. You check visual perimetry, you do a high resolution.
1 minute, Saad.
You did pituitary hormonal status, very important. The operative status, where is it a prechiasmatic or retrochiasmatic, whether there's hydrocephalus, prior treatment, if they have radiation endonasal surgery, wide variety of surgical. The recurrence is in the first 3 years, the recurrence is mostly cystic. If the lesion is calcified and involving the floor, the recurrence rate is, there's a very high chance of recurrence. The overall survival for adults is about 89 to 94% in 5-year survival, and it's the same for children. Talking about hypothalamic injury, it's one of the grave complication, either traction or injury. It can lead to hypothalamic obesity, more common in children is loss of circadian rhythm, diabetes insipidus, and congenital failures. If there's hydrocephalus, you need to put an EVD or VP shunt. Talking about cyst management, which is one of the form of recurrence, and it is difficult to manage. You can put an Ommaya reservoir, you can do serial aspiration, you can do instill radioactive isotope, you can instill interferon, or you can aspirate and reduce it to a size that is amenable to stereotactic radiation surgery. This is a paper which says that serial aspiration can be done in candidates which are not for surgery now, or in pediatric population when you want to delay radiation. Talks about brachytherapy, use of yttrium, phosphorus, and interferon. Have to mention Dr. Ommaya's name. And coming on to radiation therapy, the recurrence-free survival in 10 years after subtotal resection plus radiation is 80%. Is gross total resection a form of cure? I don't think it is, because this paper clearly indicates that even patients who underwent complete resection had relapses. Long-term outcome, we've already discussed about this. So this is a paper on quality of life, and it talks about hypothalamic sparing treatment are recommended because otherwise you will leave the patient with a grave complication. This is a registry from Germany, the craniopharyngioma group, and they talk about less radical surgical approach and to reduce the rate of hypothalamic injury. Probably this is my last slide. This paper actually shows a pathway for two different type of patients. The good risk patients are those with small tumors, with no hydrocephalus, with no hypothalamic syndrome, and no breach of third ventricular floor. You should try and excise these as much as possible. The poor risk patients are those with larger size, hydrocephalus, hypothalamic syndrome, and breach of third ventricle. Here you should go for a subtotal resection, and then you can follow patients up. If there's incomplete resection and if the patient is young, you can just wait. Older patient can go for radiation. So the summary is that craniopharyngioma is a difficult disease to treat, needs a multidisciplinary approach. You should know the goal of surgery. You should know prehand if you will be able to spare the hypothalamus or not. You should know the expected morbidities, and if needed, you should consult a regional or international expert. Thank you.
Thank you.
Oh, thank you. Saad, just one question from you, and then I just want to make a comment. And that question is, can you share any information on interferon, please? Intracyst.
I had it. I can share it later, but since the presentation was too long for 10 minutes, I can share it later. I do have papers. I can share it with you. There is a lot of interferon through the...
So it's worth looking at that?
Yes, it is. I have a paper right now. I can show it to you maybe.
Okay, I just want to say one thing, that to your last point, because you ended your talk, your comprehensive review by saying that they should be referred to centers of excellence. And quite honestly, I just want to share with you the story of a son of a colleague.
You told me that.
And the son had a craniopharyngioma, and he'd seen a number of neurosurgeons, and everybody had said to him, yeah, we can take this out, but it may not be complete, and you'll have to have radiation and so on and so forth. And he asked my advice. I said, if it was my son, I would take him to a place where I know they could take it out, and so that he would be spared radiation. And this person then traveled abroad. He went and had a surgery in a place where they do endoscopic plus intraoperative MRI. And by the way, just very quickly, endoscopic is the best way to treat craniopharyngiomas. You can argue till the cows come home. Salman is here about pituitary. I can argue with you about pituitary. You can keep telling me how your endoscopic is good. But for the standard, like the microadenomas, Khalid's not here, but like for the microadenomas, microscopic is as good. You can't convince me that. For the larger ones, yes, but craniopharyngioma, there's no question. There is absolutely no question. And for young people who want to operate on craniopharyngiomas, really you must train yourself in endoscopic and only use endoscopic. That's the best way to treat it. And so this man had an endoscopic surgery. I know from the surgical note that during the course of his surgery, he had 2 MRIs. He came back and not a shred of craniopharyngoma on the MRI. He's now recently had his 3rd year follow-up MRI. Again, not a thing. So no radiation. He's now pursuing his academic career. The only thing is that he's going to be hormonally dependent, if you like. I mean, if you look at, he's fine, but he's going to require hormones really for the rest of his life, at least something. So your last point is probably the most important. I know that we all do everything. I know that we all do, but really you need to seek out somebody who has a better chance of taking it out than you do.
Thank you, sir, Dr. Juma. Can you proceed, please?
Yes, Dr. Saad, as you mentioned in your conclusion, that craniopharyngioma requires a multidisciplinary approach, finally, because there are a lot of recurrences and residual tumors left. And as you said, that subtotal resection should be attempted if it is involving hypothalamic areas and other like that. So I, as you know, work on gamma knife, and I have presented several times my results on craniopharyngioma. So I would like to mention that gamma knife is a great tool for residual and recurrent craniopharyngiomas. And if you combine the subtotal resection with craniopharyngioma, you'll get better result. And because they are radio sensitive tumors, finally, so you should use it to the advantage. Thank you.
Is that all? Thank you.
Okay, thank you.
Thank you, Dr. Saad. Before moving on to our next talk, I would like to remind and request the participants of oral presentation part 2, Dr. Adnan Khalik, Dr. Noman Rasool, Dr. Usman Ahmed Kambo, and Dr. Munawwar Hussain to please proceed to the BMT hall for their respective presentations. So the next talk of this session is by Dr. Shams Raza Brohi, and he's going to talk about pearls for the acoustic surgery.
Bismillahirrahmanirrahim. I think it's good morning or good noon. It's maybe good morning. So, first of all, I am thankful to Professor Salman Sharif for giving me opportunity to talk on this complicated subject. I belong to Nawabshah where these gadgets are lacking. We don't have CUSA, we don't have intraoperator monitoring, we don't have the navigation system, but we have simple tool, that is the bipolar, the suction, operating microscope, and a drill. And we have got a hand. They say that in hand you have got 50 joints and you have got million movements. Before, I think, learning the gadgets, we should learn how to use our hand. Our hand is very important. So we are using hand and we are showing our results, our ignorances, our defects, and we want your help to assist us. So what we have found that we don't find small acoustic neuromas. We find large acoustic neuromas, the giant one, because people don't want to be operated unless they get unconscious or they get fell down. So they come to us when they have got a big tumor and they are in a very bad shape. So everybody knows acoustic neuroma is a misnomer. It's not neither neuroma nor it is neurofibroma. It's a schwannoma. It's arising from the inferior division of the vestibular. That is why it is called vestibular schwannoma. I don't know why sensory nerves have more schwannomas. I don't know why the vestibular and cochlear nerve, they function together. And I don't know why the 7th nerve is in a bad company of 8th nerve. Everybody, I think if anybody has an answer for that. And everybody, in juniors know the differential diagnosis of the acoustic neuromas, the epidermoid, arachnoid cyst, the schwannomas, and the treatment options, everybody knows microsurgical resection or stereotactic radiation, observation, and chemotherapy. We observe in elderly patients, in patients with small tumors, especially if their hearing is good, patients with medical condition that significantly increase the risk of operation, patients who refuse treatment, patients with a tumor on the side of an only hearing ear or only seeing eye. I consider that acoustic neuroma is as same as neurofibroma anywhere. It has got a nerve root, it has got a blood supply, it has got a venous drainage. If you know the pathoanatomy of the acoustic neuroma, you can handle it very. And I know there are two types of neurosurgeons in the world. One are handling, they are playing like a cat, and the other they are attacking like a lion. So you have to see where have to play like a lion and where to attack like a cat. And everybody knows it arises from the junction of the central Schwann cells and the central myelin and the peripheral myelin. Central myelin is formed by the oligodendroglyocyte, peripheral by the Schwann cells. The bad thing about eighth nerve is that this junction is far away from the brainstem, and it lies in the internal auditory meatus. So that is why I'm giving importance that the internal auditory meatus has got a great importance in the management of acoustic neuroma. If you don't deal with the internal auditory meatus, you will not be able to preserve the facial nerve, or you cannot completely resect the tumor. It's a prime importance. Everybody knows the tumor classification, grade 1, 2, 3. We receive all these in grade 4. They have got severe brain displacement and deformation of the fourth ventricle with under tumor compression. So you can see that there may be such large tumors with brainstem pushed on the other side, and the ventricle is compressed. They usually present with the hydrocephalus, and sometimes we find the bilateral acoustic neuromas. Such big tumors, you can see that the brainstem is so compressed. They come with cranial palsies. They have got glossopharyngeal vagal and accessory involvement, and they need NG tube. They even need tracheostomy. They even need preoperative shunting or preoperative endoscopic third ventriculostomy. So you see this patient as seem to be hydrocephalus, but if you look carefully, they have got bilateral acoustic neuroma. If you give them contrast, this is so they come in a very bad shape. Such the brainstem is squeezed between two tumors. So NF2 is another misnomer. It's not neurofibromatosis at all. It is schwannoma. It is not neurofibroma. And everybody knows the formula of two. They involve in the two acoustic neuroma. They involve two eyes, and they involve the two parts of the brain, the ependymoma and the meningioma. People all over the world talk about hearing preservation and facial nerve preservation, but we talk about life preservation because they coming in a very bad shape. We think of their life. We want to preserve their life because of brainstem compression. They have cerebellar sign. They even go to interrespiratory depression. They have lower cranial palsies, and there is obstruction of the circulation. And for that, we prefer to do ETV or VP shunt. We had 3 patients with NF2, and they were totally blind and totally deaf. So how they were communicating, I was expecting how they communicate with other person when they are totally blind and totally deaf. One patient was operated on both sides and recovered, but no improvement in vision. I've seen that when you operate, they don't have improvement in vision. And one patient had operation on one side and presented after 6 months and died due to respiratory problem. One patient had surgery on one side, and he is waiting for operation on the other side. Everybody knows about 3 approaches, but we only do sigmoid. We are only aware of that. We don't know how to do translabyrinthine and middle fossa operation. Different people, they have different approaches. I think the world over, the world champions in neurosurgery doing acoustics, they prefer sitting position. But I think in Pakistan, we are not adopting this sitting position. Sitting position is not done. We prefer 3/4 prone position. We find it's very good for approaching that. As everybody knows, axillary lows pressure points are padded, chest and hips are straightened, shoulder is gently retracted. And I think it's a great preference given to the placement of the shoulder, where your shoulder lies. If you are operating on an acoustic for 5-6 hours and your shoulder is coming in your way, that will be a great problem for you. If you displace your shoulder anteriorly, it will be easy for you.
Sir, we have 1 minute.
So we don't have monitoring brainstem or facial nerve monitoring. We don't have end-tidal PCO2. Eyes should be take care. They should be take care of the DVT. So people do craniotomy or craniotomy. We do craniotomy on this, and it's easy to do craniotomy. And then that bone can be repositioned afterwards. And if your craniotomy is flushed with the petrous bone, then you will avoid great cerebellar retraction, because cerebellar retraction gives you cerebellar continuance, and post-op patient get worse. So your craniotomy should be flush with the petrous temporal bone. And there should be opening of the cisterna magna or cisterns to get relaxation of the cerebellum. And sometimes some part of the cerebellum can be resected to avoid gentle retraction. Internal auditory acoustic meatus, I think this is the drilling of the acoustic means is very important, and it should be learned how to do internal auditory meatus. I divide into one stage you do tumor bulking, then second stage is you go to the internal auditory meatus and you drill it 5 to 10 millimeter. That gives you extra benefit. You find seventh nerve above the glossopharyngeal nerve, and then you come to the internal auditory meatus, you drill it, and you remove the tumor, and you identify the nerve, then you can save the facial nerve. Otherwise, the facial nerve preservation is very difficult. Even after drilling of the internal auditory meatus, it should be waxed, it should be proper, either maybe CSF leak through that. Endoscope can be used to visualize the internal auditory meatus, and you see the structures inside. People say that if some part of the tumor is stuck to the nerve, they can be left behind and sent to the gamma knife or other procedures. So this is our position. We keep the patient in somewhat lateral position and place the shoulder anteriorly. And we have got a support for our two hands. When you are operating in microscope and you are handling like that, you must have a support for your both elbows. Otherwise, you will get tired. And that is very important. So in conclusion, early detection of the tumor, preoperative management of hydrocephalus with VP shunt or ETV, proper position of the patient, debulking of the tumor, avoiding excess or use of bipolar. I still insist people, they use 1,000 times of bipolars in single acoustic. That makes the tumor like a charcoal. Your arachnoid plane is gone. You will inadvertently damage the nerves. So if you want to protect the nerve, don't use excessively bipolar. Drilling of internal auditory meatus is very stressful. Identification of the nerves at meatus near 9th and near pontomedicular circles. Post-operative care is very important, NG feeding and tracheostomy. That is very important in post-operative care. So thank you very much for patient listening this very basic talk after listening to very hi-fi talks. Thank you very much.
Thank you.
Shams, thank you for sharing your thoughts on acoustic, because, you know, to my mind, particularly if you're working in a government hospital, yes, acoustic neuromas are a very, very humbling experience. Mm-hmm. There's nothing, no tumor or disease pathology that I can think of in neurosurgery that humbles you and brings you down to earth as much as an acoustic neuroma does. I want to ask you a question.
Yes, sir.
You describe the skills that we must have or the methods we must have to remove the acoustic. Mm-hmm. But now that we have access in Sindh we have access to 3 stereotactic radiosurgeries, and a 4th one is just about to come online. So do you think that the skill needs to now shift from removing the acoustic to debulking it, yet preserving all the vital cranial nerves that are in front of you?
Well, what we have found that if you debulk and leave other tumor, because tumor is already pressing the brainstem is pushed on this side, the nerves are involved. They are not going to reverse back. You have to decompress the brainstem as well, because the brainstem is so pushed. If you leave that, that is not going to come back again, even after gamma knife or radiotherapy or anything. So that has to be done mechanically with your surgical maneuver. You have to decompress. That is my humble submission.
To be very honest, I have been doing these large CP angle schwannomas, and I have always debulked the tumor, and then, if required, go for radiotherapy, and now gamma knife. I believe that this is how you can preserve a good life for the patient, because when you give them a lower cranial nerve palsies, or you give them facial nerve palsies, they are never happy.
If you think
may I finish?
Yes, sir.
Of course, if you are in Europe and places where you have small tumors where you want to preserve hearing and stuff like that, that is different. But this is my personal opinion. Thank you.
But what we have seen, we haven't seen any patient with the hearing. Hearing is already involved. What we are thinking that if some part of the tumor which is adherent to the nerve, and by removing that, the nerve may be damaged, that can be left for the gamma knife or something. But a big chunk of tumor which is compressing the brainstem, if the brain is pushed like that, I think it's not going to have some benefit of gamma knife. Thank you very much.
Thank you, Dr. Shams. So this session ends here, and now we are going to proceed on to our next session for oral abstract presentation, part 2. For chairing this session, I would request Dr. Raza Rizvi to be seated and moderator Dr. Amir Muhammad Saki to be seated. So the first presentation that we are going to have is by Dr. Murtaza Ahmed from Fatima Jinnah Medical University, and he is going to talk about surgical approaches to lesions involving the orbit.
Presenters, kindly stick to your time limits. Thank you.
Bismillahirrahmanirrahim. I'm Dr. Murtaza Ahmed, and I'm from Fatima Jinnah Medical University / Sir Gangaram Hospital, and I'm resident neurosurgery, and our department is being headed by Professor Dr. Abdul Hamid. Today, I'm going to present surgical approaches to the lesion involving the orbit. Orbit has a complex surgical anatomy. The surgical treatment of orbital lesions is a multidisciplinary team approach. Neurosurgical domain in orbital lesions come to an end when cranial lesions are extending into the orbit, or orbital lesions that are not confined to the globe. There are a number of surgical approaches that can be used to gain and access the orbit. The optimum approach is determined by a number of factors, including size of the lesion, its location inside the orbit, extension outside the orbit, as well as the surgeon's objective. When surgical objective is complete excision, the orbit can be exposed through lateral orbitotomy approach, supraorbital craniotomy, pterional craniotomy with fronto-orbitozygomatic approach, and infraorbital orbitotomy. At our Department of Neurosurgery, Fatima Jinnah Medical University, Sir Gangaram Hospital, a number of patients were presented with orbital pathologies. Others were referred to our department from ophthalmology for surgical management. The purpose of our study is to evaluate the different surgical approaches used in patients operated in our department for orbital lesions. to study the versatile all around the orbit surgical approaches, per-op findings, and histopathological findings of patient presenting with lesions inside the orbit. This prospective study was carried out in our Department of Neurosurgery, Fatima Jinnah Medical University, Sir Ganga Ram Hospital from November 2015 to May 2021. It included all those patients with orbital pathologies which were admitted through outpatient department or shifted from other wards and subsequently operated in our department. CT scan or MRI of the brain of the orbits were radiological investigations used separately or in combination as when required. The surgical approach was planned in each case according to the location of the lesion inside the orbit as well as its extension outside. Data regarding patient demographics, clinical history and examination, radiological findings, surgical approach used, operative findings, and histopathology was collected on a performer. A total of 28 patients were included in our study. The age ranged from 8 to 62 years with a mean age of 28.5 years. 10 patients were male while 18 patients were female. All the patients had varying degree of proptosis on the affected sites. 24 patients had headache, 10 patients had lesions confined to the orbit, 12 patients complained of visual deterioration, 12 patients had lesions involving the orbit as well as the nose and paranasal sinuses, 6 patients had orbital lesions with intracranial extension. Supraorbital craniotomy was the most common approach used in 12 patients. 10 patients required lateral orbitotomy. Frontotemporozygomatic approach was used in 4 patients, and 2 patients had removal of the inferior orbital rim. The histopathology of the patient included in the study were 14 patients had benign lesions. Benign spindle cell lesions were in 8 patients, meningiomas in 3 patients, neurofibroma in 2 patients, ossifying fibroma in 2 patients, and fibrous dysplasia in 1 patient. Infective pathologies that were found in 12 patients were 6 had chronic non-specific inflammation, 4 had chronic granulomatous inflammation, and 2 had fungal granulomas. 2 patients that had malignant pathologies was adenoid cystic carcinoma and non-Hodgkin lymphoma. So this is our first case, a young female that presented with axial proptosis, and the MRI of the patient showed that the lesion was confined inside the cavity just behind the globe. We used fronto-orbitozygomatic approach for this patient. As in the second picture, you people can see that the bone flap which was raised contains zygomatic arch, lateral orbital rim, and the frontal bone, portion of the frontal bone. In the first picture, you people can see that we retracted the brain and the tumor was peeping out of infratemporal fossa. After the gross total excision, we can see in these images that the proptosis was gone and by using this approach. This is a second case, a young child who had a recurrent tumor of the left eye. He presented to our outpatient department and we approached the same, we used the same approach for it. As on the images, you people can see that the tumor is involving whole of the orbit and it is compressing the globe forward. And the lesion is also extending medially into nose and paranasal sinuses. The angiogram of the patient showed high blush, that is, it was richly supplied. We use the same approach, that is the frontotemporo or orbitozygomatic approach. This is the intra-op picture. The first picture reveals the we raised the bone, first of all the skin flap, and then in the next picture we did the craniotomy, and the tumor was coming out from the infratemporal fossa. The bone flap being raised, and we excised the gross total tumor. This is the gross total picture showing the gross total excision of the tumor. And after that, reconstruction was done and the bone flap was replaced. This picture shows the comparison between pre-op and post-op picture of the patient. The next case is an example of inferior orbitotomy, orbital orbitotomy, in which a young female presented to us with right-sided proptosis, and as you people can see in the slides that there is the rolling up of the eye on the right side. The tumor on images was lying inferiorly and laterally, and it has no extension apart from it. So we used the infraorbital orbitotomy. This is the inter-op pictures of the patient, and skin crease incision was given for cosmetic purposes and bone flap being raised, as you people can see in the second diagram. After removing the bone flap, the tumor was excised totally, and it was then reconstructed with titanium wires. This is the picture that is showing the pre-op and post-op pictures. The next case is the patient, a young male, presented to us in our OPD with left-sided proptosis, and the tumor was lying superiorly, and it was not extending into the cranium, and we used supraorbital craniotomy approach. This is the post-op X-ray of the patient that shows a bone flap being raised involving the superior orbital rim, and the post-op picture of the patient. This is the orbital tumor after excised. Conclusion. Orbital lesions pose a challenge to the operating surgeon due to a variety of lesions having different locations, as well as the number of approaches that can be used to access the orbit. However, the choice of the correct surgical approach for each lesion depends upon the location of the lesion inside the orbit, as well as its extension outside it. And thus, it requires a sound knowledge of the surgical anatomy of the orbit, as well as the location of the tumor according to the radiological study. Thank you.
Thank you very much for that presentation. I want to congratulate Professor Hamid for continuing his interest in the orbit. As I look back at my neurosurgical career in Karachi of about 35 years now, there are a number of disease pathologies which have escaped the orbit of the neurosurgeon. For instance, some of the aneurysms, a lot of the acoustics. And you know what? I don't mind that. I don't mind that because it's good for the patients. A lot of patients who used to suffer because of traumatic CP angle surgery or re-ruptured aneurysms are now saved. The one pathology that really hurts, that we just don't do it because we should be doing it, is orbital pathology. And we've let that slip away out of the orbit of neurosurgery into the grasp of the ophthalmologists. And I'm not quite sure how to do this, and maybe Hamid Saab wants to say something, but we really need to make an effort to bring this thing. I really think we do a better job at orbital pathologies than the ophthalmologists because we have the ability to approach it from all directions. And so I just urge everybody in the room to take an interest in this. And Hamid Saab, congratulations again.
I would request the participants to try complete their presentation in 7 minutes so we can have a 2 to 3 minute discussion following their presentation. So the next presentation is by Muhammad Shahir Akhtar from Lady Reading Hospital, Peshawar, and he is going to talk about transoral orontectomy, our experience in a limited resource setup.
Sir, I just want to ask that you are my stimulus. I have seen you in 1997 doing a orbital tumor at your place, and since that, it was my ambition to do these orbital tumors myself. Thank you very much, sir.
इसमें नहीं है सेशन 1 में उन्होंने डाली थी कौन सी थर्ड नीचे ये हाँ मैं सेशन 1 में कॉपी करवा दी मैं वहाँ ढूंढ रहा हूँ Assalamu alaikum. I am Mohammed Shahir Akhtar, postgraduate resident, Lead Hospital, Peshawar. So the topic of my presentation today would be transoral odontoidectomy for congenital basilar invagination, our experience in limited resources setup. So basilar invagination in simple words is the abnormal prolapse of the odontoid process into the already crowded foramen magnum. It is usually accompanied by atlantoaxial dislocation, and it usually doesn't occur alone. There are other associated pathologies like atlas assimilation, syringomyelia, anomalous course of vertebral artery, and congenital fusion of the upper cervical vertebra. These all are relevant to the surgical intervention because they make the anatomy of the region very complex. So traditionally, basilar invagination was divided into two groups by its reducibility. If the alignment was achieved via extension or preoperative traction, then a posterior fusion only would be performed. But if full alignment couldn't be achieved by these methods, then anterior decompression via transoral odontoidectomy or transnasal, transclival, or any other approach followed by a posterior fusion for the irreducible type. So since the last 2 decades, the treatment of this has changed dramatically since the advent of posterior distraction by Goel, and recently Chandra's DCER, distraction, compression, and extensive reduction. Now almost all cases are advocated to be treated from the posterior only approaches. So are there still indications for transoral odontectomy? We performed transoral odontectomies for severe compression due to atlantoaxial dislocation and basilar invagination that cannot be managed with a posterior only procedure that we think is unsafe in our hands to be managed with a posterior only procedure. It is also used as a salvage procedure after a posterior only approach if it was unable to completely reduce the pathology, and for other inflammatory or infectious causes compressing the CVJ. So what do we mean by limited resources? We work in a government hospital. A significant portion of our patients cannot afford modern implants or gadgetry. We perform these procedures without the neuromonitoring or navigation, and we have limited HDU and ICU facilities. The study was performed in Neurosurgery Unit Lead Hospital, Peshawar from 2017 to 2020. 21 patients with AAD and BI who fulfilled the criteria were included in this study. Infectious or inflammatory pathology, history of trauma, and tumors were excluded from this study. So diagnosis is made in a standard fashion with the McGregor line, Chamberlain line, McRae line, Wackening line, all those standard textbook methods. So surgical procedures, the patient lies supine on the table in a slight Trendelenburg position. The neck is slightly extended and a fiber optic orotracheal tube is passed. Tracheostomy in our setup is only reserved for very severe preoperative bulbar respiratory disturbance, especially because there are limited postoperative ICU facilities available. A low-profile self-retaining transoral retractor system is used. Uvula is retracted away. C1 tubercle is palpated and confirmed on image. The midline incision is made from the clivus to C2-3 intervertebral disc. Anterior arch with odontoid is resected and NG tube is left in place. And the patient is then shifted into a prone position, and posterior OCF or C1, C2 is formed depending on the pathology. If there is atlas assimilation or whatever could be possible in that set. So both are preferably done in the same setting. However, we have performed 2 patients of these 21 in 2 different settings due to a variety of reasons. So a total of 21 patients with a mean age of 21, 8 who are female, 13 male. The most common presenting complaints were gait instability and limb weakness. The associated abnormalities, the most common was atlas assimilation that was found in 66% of the patients. C2, C3 fusion, clipal field was found in 3 patients, 14%, and anomalous vertebral artery also in 3 patients. We measured the neuric scores pre-op and post-op and modified Japanese Orthopedic Association score. So pre-op and the score that we have compared it with is with the final follow-up. So the neuric score improved from 2.29 to 0.95 on the final follow-up, and modified Japanese Orthopedic Association scores to 11.6 to 14.9. These are some of the cases. This is a 12-year-old kid. The consent has been taken from the patients regarding their identity. This one with the almost vertically oriented C1, C2 joints that we thought was unsafe from posterior, and the C2-3 vertebrae were fused and the C3-4-5 were fused. And this one with LS assimilation. So the complications in our setup were, in these 21 cases, we had 2 vertebral artery injuries. Both patients were diagnosed post-operatively with increased bleeding from their wound site in the wards. Tracheostomy was performed in 3 patients. There was tongue swelling in 1 patient post-operative. The wound infection in 2 patients, chest infections in 2 patients. Among the vertebral artery injuries, 1 was managed conservatively post-operative. After management, the angiogram showed no anomaly and the patient had no neurological sequelae. However, 1 patient developed a pseudoaneurysm that was surgically treated.
You have 1 minute.
Okay. So a mean follow-up of 6 months was completed. Symptoms significantly improved in 90% of our patients. The conclusion is, in the setting of a low resource setup, transforal odontoid resections can be safely performed for select patients that are properly selected according to criteria. Thank you.
Mic there, please, Dr. Junaid.
It is a very nice lecture, and as Professor Juma already told, that orbit is the thing where the neurosurgeon play very little attention. I think this approach is much more needed by us. The only thing is that we always are worried that we have to involve the ENT surgeon like that. But personally, I did 3 cases. It is a very simple approach. You can go transorally and you give the incision and very little bleeding, and you read directly to the odontoid process and the other thing. So I would ask the youngster to get full experience of it. Nothing else is needed. No stereotactic and nothing like that, but you get very good results and you will get a lot of cases also.
Thank you.
Thank you very much.
Actually, I trained with one of the giants of neurosurgery who used to do transoral work, and Rashid also trained with him, Alan Crockart, and we have got a good sort of experience with him. And I think it's, this is something, those patients have got very significant compression from the front and who've got severe neurological deficits should always be approached from the front. First decompression, then fixed. I don't know how they can fix from the back and get neurological improvement. I've never seen that happen. We always need to do that. Transoral decompression can be done. It can be done safely if you take all the adequate precautions. We always do tracheostomy. I don't think I can just trust an endotracheal intubation because there is so much of post-operative swelling of the tongue and the pharynx after surgery for 4 or 5 days. So you need to have a tracheostomy. It's safe to have that. And I don't think it's very difficult to manage. And once you have done that, I think I've been doing all these procedures under spontaneous ventilation, and we get very good results with that. Very little complications, but you've got to select your patients.
I usually agree with Junaid nearly always. This is one place where I won't agree. It's been now 6 years since I did a transoral. Every time we have reduced it and we have shown good results, and we are about to publish it. So, and majority of my friends worldwide who used to do transoral have gone away. I think if you look at maybe top 20 spine guys, I think none of them are doing transoral anymore because we can reduce it from behind. It's very, very easy every time we reduce it. So, and usually you don't require these big fixation, you just need C1, C2 fixation. That's all you need. The problem is C1, C2, not the CV junction. So I think we just need to be careful. What we suggest in our guidelines now, the spine guidelines suggest that it should be meant only for those patients that we can't reduce. And I haven't seen a patient in 6 years. Talking to Mehmet, he hasn't seen a patient in 6 years. Ed Benzel has not seen a patient in 6 years that we can't reduce. So I think it's possible.
Thank you. Now I would like to request Dr. Iqbal Ahmed Kharal to come and present. He's from DG Khan Medical College and Teaching Hospital, DG Khan, and he's going to talk about efficacy of laminoforaminotomy for unilateral cervical reticulopathy.
Thank you very much. So we are going to talk about the outcome of laminoforaminotomy in case of unilateral cervical radiculopathy. Cervical radiculopathy is the clinical description of pain and neurological symptoms that irritate the cervical nerve root. The causes include herniated disc, stenosis, degenerative disc disease. There are different approaches that include anterior and posterior as well. So benefits of anterior versus posterior: good visualization of pathological changes in case of anterior, stabilization of motion segment, direct and indirect decompression of enlargement of neural foramina. Muscle sparing approach, post-op absorption of residual osteophyte, also relieves the central stenosis, useful in axial neck pain, restoring the lordosis. No neuronal retraction. While benefits of posterior approaches are no need for fusion, no complications of segment fusion, direct decompression of neuronal tissue, post-operative immobilization unnecessary, less risk of visceral damage, useful in smoker, athletes, and singers, useful for C7T1 in obese patient with short neck, useful for recurrence after ACDF. So disadvantages, indications for both. For anterior instability, hard disk, coexisting central canal stenosis, bilateral disease, more than 3-level disease, axial neck pain, and kyphosis. For posterior, the indications: when there is no instability, the disc is lateral and soft, younger patient, preferably unilateral, and it can be done in single level or in multiple level cases. So usually posterior cervical foraminotomy, the whole disc is not removed, just the fragment pressing the nerve root is removed. Fusion is not performed. Typically do not require a neck collar after the surgery. Kindly इसको देखिए. Okay. The aim of our study was to report the outcome of laminoforaminotomy in unilateral cervical radiculopathy. It was a 3-year prospective study which included the unilateral cervical radiculopathy at single level. We excluded the bilateral radiculopathy patients with myelopathy, spinal instability, and kyphosis with follow-up of 6 months. So these are the post-operative images showing neuronal decompression with posterior foraminotomy of C6 radiculopathy. This one is a post-op X-ray showing right-sided C6 foraminal decompression. So outcome was measured according to the ODM's outcome classification in early postoperative and 6-month postoperatively. All preoperative symptoms relieved. It showed the excellent result. When minimal persistence of preoperative symptoms were present, the result was good. And in fair cases, definite relief of some preoperative symptom, but other symptoms unchanged or slightly improved. When the symptoms and signs unchanged or exacerbated, the results were poor. So analysis was done. There was 10 male and 7 female patients. The mean age was about 45, and the duration of symptom was 1 to 7 months. By clinical examination, neck pain was mild in 2 patients, moderate in 3 patients, and severe in 12 patients, while brachialgia was severe in 5 patients and worst in 12 patients with no sign of myelopathy. So results showed 5 patients of C5 radiculopathy, 8 patients with 6 radiculopathy, 2 patients with 7 and 8. Final outcome at 6 months, excellent in 52% cases, 40% showed good outcome, fair in 5%, and 2% poor, 2.5%. So overall outcome was 93% satisfactory and 7% unsatisfactory. We found some complications like superficial wound infection, temporary motor weakness, permanent paresthesia, and motor weakness as well in 5 patients. Although the anterior approach for the treatment of cervical disc prolapse and spondylitic cervical canal stenosis is more commonly performed and studied, cervical foraminectomy for cervical radiculopathy is an effective option in well-selected patients with posterolateral foraminal stenosis in either soft disc or osteophyte for nerve decompression. Thank you.
Thank you, Dr. Iqbal. Now we are going to proceed on to our next presentation, which is by Dr. Hassan Amjad, and he is from Fatma Jinnah Medical University, Lahore, and he's going to talk about stereotactic biopsy for deep-seated brain lesions.
Assalamu alaikum everyone. I'm Dr. Muhammad Hassan Amjad. I'm from Sangangaram Hospital, Lahore. And today we're going to talk about the diagnostic yield of stereotactic biopsy using half-arc ZD frame system for deep-seated brain lesions. Well, as you all know, the indications for stereotactic biopsy include first is the biopsy of the deep-seated lesions, aspiration of the cyst or hematomas, staging of the neoplasms, and also for the placement of Ommaya reservoir or intraventricular catheter in cases of benign intracranial hypertension, and also for functional neurosurgery, including lesioning and DBS. A little bit from the history, stereotactic biopsy were first introduced by Spiegel and Weisses in human beings around 1947. They developed a Horsley-Clark frame that was first one to be used, which was based on Cartesian system. It was introduced around 1950. Lexell then brought upon a revolution, and they incorporated polar system into the system, and their full arc frame system was first used around 1955. Since then, multiple advancements have been made, and now we have developed half arc frame systems. Few examples of full arc frame systems include Lexell frames, RM frame by Ionomed, and CRW frames. And among half arc frame system, we have ZD frame, Zumrano de Giovanni frame system of Ionomed. This one is a Lexell full arc frame system. This one is an RM, and this one is a CRW full frame. As it is clearly evident that these frames are very bulky and heavy and with complex machineries. This half-arc frame system is apparently very easy to use with few mechanics. So after choosing our patients, we place a head ring on the patient, which accompanies the frame, and the patient is placed in the, for imaging, since it's titanium, it can be CT or MRI. And this is the frame. After getting our images, we transfer them into the computer system, our IPS. It's very simple to use. Software is very easy to handle. You just mark the lesion and the entry point of your entry point for the biopsy. After marking your entry and target, it just gives you the simple calculations. It shows an average error of 0.26. It's acceptable up to 0.3 in that system. These are the calculations that are given by the software. As you can see, it has values for target lesions as well as values for the mounting arc. So this is a phantom frame. One of the most beautiful feature of this frame is the availability of phantom frame. After getting your lesions, this is the head frame and these are the different biopsy needles. This is the complete setup, the arc systems and the biopsy needles. The best point of this system is the availability of a phantom frame. After getting your target values and your arc values, you apply this on this phantom frame and make sure that your points coordinate at the similar point. The bigger needle points the target lesion, while this is your biopsy needle. That is why it has an accuracy of up to 1 millimeter. So after this, the frame is removed. The head ring is set in place. Patient is set for biopsy. Now, since you have already calculated the lesions of the frame, the arc, you just remove it from the phantom frame, and this pre-calculated frame is mounted on the head ring of the patient. This lets you give lets you take the biopsy of the patient. One of the best features of arc system is that you can manipulate your entry point since it's center based. So you can change your entry point, but it will always mark towards the lesions. A simple burr hole is placed and biopsy is taken. The objective of this study was to assess the diagnostic yield of stereotactic biopsy for deep seated brain lesions using this iNOMED Zimmermann Giovanni half-arc frame system. We performed a retrospective case series. We included 16 cases from January 19 to January 2020. However, we got slowed due to COVID. We could only include 16 cases in that, and histopathology was used for the assessment of the yield. 10 of our patients from 16 patients were female, while 6 were male, and our biopsy results were 100% positive. All 16 patients were showed positive biopsy in our yield, histopathology. So in results, we used 16 cases of supratentorial brain lesions. Biopsy was positive in all of our cases. Only one patient developed a small intracranial hematoma at the site of lesion, but it was managed conservatively. Patient did not develop any morbidity or any deficit later on. There was no post-op infection noted. We found a study that showed that was a case series of 421 cases. It was done in Rome. It was done over 16 years. And they showed that they increased their yield by the use of... 2 minutes. 2 minutes. They showed that their yield only improved after the use of intraoperative frozen sections. There were other studies cited in this cited for this that showed that almost all of them improved their yield by introducing intraoperative frozen section and histopathology analysis. There was one other study that also used similar ZD half-arc frame system, and they used intraoperative MR scanners to improve their yield. And they noted that after the incorporation of intraoperative MRI, their biopsy, their yield only increased by 0.8%. It was 96% without MRI and 96.8% with the use of MRI. So in conclusion, it is our ZD frame, iNOMED Zimmermann frame system is one of the easiest frames to use. That's why it's also known as lady frame. It has 100% diagnostic yield, less bulky on the patients. The software is very user-friendly. You can get CT or MRI, and they can be merged to get a very good 3D view. It has built-in atlases that are particularly very helpful in cases of functional neurosurgery. And one of the most prominent and most beautiful feature of this is the availability of phantom frame. The availability of phantom frame lets you check and let you verify the accuracy of their targeting before you proceed onto the patient. So you do not have to repeat for biopsies, and only one is enough. Thank you very much.
Young man. So I'm a little surprised that you're equating easy use with ladies, because I think it should have been the other way around. So that's my first comment.
Sorry, sir, no offense to anyone out there, but I'm not the one who coined this term, so.
All right. My other question, the question to you, and quite honestly, it's a question I've asked myself as well quite a lot, is that are there situations, if you have neuronavigation, most biopsies are now being done by neuronavigation. So from your experience with frames and with frame-based biopsies, can you think of occasions or situations in which frame use for biopsy is better than using neuronavigation?
I cannot think of any situation.
Sir, as we are using these stereotactic frames, initially we were using the Lexel. Nowadays we have ZD system. We are much well versed of these stereotactic frames, and by the availability of this phantom that has confirmed us that we are 100% at the accurate site. We have neuronavigation still 7 with us for the last 3 years, but we are still not of the opinion that this only navigation will make us sure that we are exact on the site. We feel much easy with this stereotactic frame as compared with this Stellis 7 till now. It's my personal experience till now. Inshallah, sir, we will. Inshallah. Sir, thank you.
Just me. It's a very good paper. I don't comment more, but for your information, each and every frame have got the phantom base. If I have got CRW, I have got phantom base. If I have got Lexel frame, I have got phantom. So phantom base is present with every frame to confirm whether you are at the right place or wrong place. And I think well done. It's a very good presentation. Thank you very much.
I'm sorry. I think what we're going to do is we're going to interrupt this session here. I apologize. The reason being that Professor Franco Cervedi has to go to theater in about 25 minutes. So we'll try to get him in first, and we'll go on to the session that is after. It was supposed to be the trauma session. And what we will stop, and they will have you back. I apologize that I'm doing this. It's just I want to make our foreign people who are giving a talk. So ask them to come and give their talk first, and then we can move on. Okay, so Professor Tariq Khan, would you be able to come and chair the session along with Atiq and Asim Rahmani? Professor Atiq, is he here? Oh, he's on the other side. Ralph, would you like to please come and do that? Are we connected? Tariq Saab, you will take over from here? We already connected. So I apologize. I apologize, everybody. We're going to carry on with that session after this session. Thank you.
So Dr. Franco Cerveri from Italy is going to present controversies in head injury.
Hello to everyone.
We
can
can't
you
hear
hear
you.
me? Hello?
Yeah, we can hear you.
Okay, can I proceed? It's okay for you?
Yes, please.
Okay, so first of all, many thanks for the invitation and sorry, but we had a lot of problems with understanding the time difference. And today, Saturday, I have to do the greet ward round in the hospital, so I will be leaving in half an hour. So I am very happy to be invited by the Pakistan Society of Neurosurgeons. I have been visiting Pakistan already 3 times. I know many of you, so I'm very happy to be with you today. I thank Salman Sharif and Tariq Khan for the invitation. Now I share my screen. And, okay. If you just confirm me that you can see my screen.
Not yet, Franco.
Yeah, I wait. Now my computer says it's sharing.
Yes, we've got it.
Oh, okay, then I go. I have limited my presentation to only 12 minutes, so I don't speak about every controversies we have, but these are my disclosures. But only one controversy, it's if we do have raised intracranial pressure, we usually have to decompress the patient. Do we have alternatives to decompression, means hinge craniectomy or cystinotomy? Because in the web, even in papers published, it seems that there is a large discussion about can we avoid decompression to control intracranial pressure as neurosurgeons. These are more than 5,000 cranial decompression done in Europe, and you see that most of them are related to trauma, but we also have vascular tumors and so on. So is decompression a panacea, as we say in Greek or in Latin? The panacea, it's, as you see, the panacea, it's about, you know, that's, it's about treating everything with the same technical approach. We do have in decompression at least 2 class 1 published studies. One is the DECRA study. It's a study limited to patients with diffuse injury with an ICP over 20 for more than 15 minutes who had a bilateral bifrontal decompression. And as you understand, and you see it here, the decompression produced a deep decrease in intracranial pressure, but the result, you see it here, especially concerning vegetative states and severe disability, were worse in the surgical part of the study in decompressive craniectomy. So the conclusion was that we cannot base the indication for decompression only on ICP, and that bilateral decompression does not work in diffuse injury with ICP over 20. Then we have the rescue ICP study. You all know it, 400 patients coordinated by Cambridge. The protocol for management is clear. ICP over 25, we do whatever we can for a medical treatment. Then if the ICP is not controlled, we randomize the patient between continuing medical treatment, including barbiturates, or surgery and decompression. The results, you see it here, you see on the left, the black side, almost double mortality in the medical group, almost double morbidity in the surgical group, and better, good results in the surgical group, but not to a statistically significant degree. The outcomes are deeply changed. This is a complicated slide, but I made it easy. If you wait until 12 months and you treat the patient for a long time, then the result of the surgical group are better, both in the DECRA and in the rescue ICP. What does it mean? That treating the decompression by placing a cranioplasty or treating the associated hydrocephalus is helpful to improve the outcome of the patient. So we need a long treatment of these patients after decompression. And the guidelines after the publication of these two papers stated that we don't have evidence, strong evidence in favor or against decompression, but we have done, together with some Pakistan colleagues also, a consensus conference in Cambridge, and we have made some recommendation for decompression, especially in fields where we don't have class 1 studies like subdural hematomas. So the question now, the hot question is, do we have alternatives to decompression? One alternative is the hinge or floating craniotomy, which is raising the bone flap without taking it out. And this has been written from many countries. You see, this is Nigeria. It's a paper about the concept of what we call hinge craniotomy, raising up the bone flap. This is India, where they published the so-called oscutaneous bone flap, the bone flap linked to the muscle and raised up after decompression without taking it out. This is Brazil, different technique, cutting the bone and splitting it out to increase the volume. This is in China. You see the same concept, raising the bone with plates and screws and then coming back and putting the bone down. So the hinge craniectomy has an important future, but we also need to understand when it is indicated. We have evidence that is not worse than decompressive craniectomy, but we have no studies to confirm it. The other technique is the cystonotomy, with or without decompression. There is a full philosophy behind the cystonotomy. I make it easy. Opening the cistern is not only helpful to reduce intracranial pressure, but is also helpful to reduce the passage of CSF into the brain. You see it here. So everyone in the room where I've seen you are knows how to open a cistern, a basal cistern. We have many single cases papers, but we have only 2 papers with more than 5 cases, who are two papers, one from Europe, one from India, with 40 patients. This is a paper from Europe, from Lausanne, Switzerland, where they randomized 40 patients were randomized. They included retrospectively 40 patients, 18 with the decompression plus cystonotomy, 18 only with decompression. The ICP was better controlled in the cystonotomy group, as well as the outcomes were a bit better, but not significantly better in the group of patients with decompression plus cystonotomy. We wrote an editorial in the same paper, in the same issue of ACTA, but you know, this editorial revealed what is the status of cystonotomy. After we wrote the editorial, there have been many other papers about cystonotomy, and some of them cited only the paper by Giammattei without the editorial, and some of them cited only the editorial without the paper. So it means that in the community, there are two different religions. What is the limit of this paper? That the randomization was only done on the basis of the availability of a vascular surgeon to open the systems. So the patient is not randomized. If we have a vascular surgeon, we do the cystonotomy. If we don't have it, we don't do it. And obviously, this is an interesting technique. But again, as for hinge craniectomy, we need a very well done randomized study. This is the Indian paper, again, with 40 patients, same results with slightly better, slightly good outcomes in the group of cystonotomy. As you see, the limit is only one surgeon, one microvascular surgeon, and the outcomes are too good to understand that the indication were the same as for decompression. But again, the editorial from Professor Chandra, the editor of Neurological India, it's the same as before. We need more studies to settle down these queries. So we have a lot of limitation. You can read it here. It's difficult to retract a swollen temporal lobe. There is a learning curve. It may take time to complete the procedure of cystonotomy in a patient with a swelling post-traumatic brain. And again, we have to avoid injuries to vascular structure and optic nerves. So what we have to accept that science cannot jump. We need in surgical innovation that we are in favor of surgical innovation. We need a rigorous evaluation before to understand if it's working as a standard technique or not. But this, the website doesn't wait. And in the Facebook, in the Neurosurgical Cocktail, the largest forum for neurosurgery, you see that after this discussion, there was a lot of question about, do we need really neurosurgeon who write the books and papers, or we need only people who can operate nicely? And this is a wrong question. The neurosurgeon says our old Harvey Cushing keeps saying is a mixture between moving hands and brain. So we need to move our hands, but also to publish what we are doing. So we need to wait until we have good indication. And just to finish, I want to show you one case, how difficult it is to decide. This is a patient with a brainstem hematoma and large contusion, but only 15 years. The relatives were desperate, so we decided we could decompress the patient, and actually the follow-up was a misery with all possible complications, 11 surgeries, and he died after 6 years of persistent vegetative state. So what we have to think is not where we want to go, probably, but think about indication for decompression. Indication for any measure is an extreme measure. We cannot only decide on the basis of a medical indication, but also there is a social context, a context of the society who is able to treat the patient with a severe disability, many other considerations, and on the top, the need for very good studies. As we say in Latin, primum non nocere. So I thank you for your attention. I'm sorry to have disrupted your interesting hybrid, I will call, conference, and I hope to see you in person as soon as possible.
Franco, thank you very much for this very excellent, informative talk. Professor Franco Salvador has been is a great friend of Pakistani neurosurgeons. And I must add that since he has been president of the World Federation of Neurosurgical Societies, neurotrauma has been center stage and it's taken its place where it belongs. I believe hinge cranioplasty would be a good addition to the armamentarium because it would prevent a second operation, but we need to do more studies on that, which are going on at the moment. And Franco, thank you for giving a balanced opinion viewpoint on cystonostomies. So any comments on this, Professor Juma, maybe you would like to?
No, Tariq, just to say that he's laid it out really well. You use the word balanced, which is absolutely correct, because there's been a huge amount of hype about this, and the enthusiasts will tell you how good it is, but a bit like the issue about doing emergency surgery and having to do, which Khalid was talking about, in the emergency setting, if this was to become a universal procedure, then we would, on a larger level, be doing a disservice. There's no question about that. And he's alluded to that, about saying that, if the neurovascular surgeon is there, then we'll do it. If the neurovascular surgeon is there, we won't do it. So if this was to become universal practice, this would be a very difficult situation. And but those risks would be worth taking if the benefit of cystonostomy was demonstrated in a well-designed randomized control trial.
Okay, thank you very much, Professor Salvador. We all hope to see you in real time soon. Thank you very much.
Thank you all for the invitation, and I hope to come to Pakistan again as soon as possible. Bye. Thank you.
Professor Sarvedi, there is one question from my side. I am Dr. Mumtaz from Peshawar. I was working with Professor Tariq Khan.
Okay, go ahead.
Though the concept of decompressive craniotomy is coming for the last, 2-3 decades, and most of our colleagues, they are following it. Still now, I am not clear what is the right time of performing this procedure in those cases when we see patient with closed head injury and we don't have ICP monitors. You see, because in literature it is mentioned that you perform this procedure after 48 hours if you cannot control the ICP. So we don't have ICP in our system here where we are working, and we use this usual osmotherapy, agents. So still I'm confused and I'm not clear when to perform this decompressive procedure. Can you clear this, please?
Yes, you have asked a very important question, which behind we have a thinking of all of us. If you see the randomized clinical studies and the guidelines, they all come from the West countries, where we do have monitoring, everything. So the guidelines are part of a situation where you are not there. So I understand the difficulties to decide when you don't have what you need to decide. This is obvious. What we need for the future is to understand that the guidelines have to be applied in countries like Pakistan, where trauma is an endemic disease, much less in Europe, where we have very few traumas. So what I can tell you is that, as you said, whenever you have a CT scan who is going worse, especially with midline shift, well, I mean, an increase in midline shift, in spite of mannitol and whatever you do, it is better to decompress the patient within 48 hours. We have proofs that it works much better. But as I told you, it is time to rethink about the process of evidence-based medicine and guidelines, because we desperately need the guidelines to be applicable to countries where trauma are, not to countries where trauma are limited.
Yes, thank you very much. There was a great paper from Colombia by Andrew Subiano on resource limitation guidelines, and we wrote a commentary on that, that guidelines can be low level and slowly increase to that. And also, if you look at Randy Chester's paper about the ICE protocol, that you can look at in low resource setting, imaging and clinical examination, and use that as guidelines for decompressive craniotomies. So any comments? Or so thank you very much once again, Professor Savade, for your talk. Thank you.
Thank you. See you soon.
So now I would like to invite our other good friend, Dr. Laura Lipa from Livorno, again from Italy. And she has been to Pakistan, Peshawar also, and she's going to talk on cranioplasty complications. So Laura,
yeah, I'm here.
Online?
Thank you.
Yeah,
yes. Thank you, Professor Khan. Thank you for having me. Thank you for inviting me. I'm delighted to be with you. Also, I would have loved to be in person, but hopefully next year. It's a very nice thing to talk after Professor Trevade, because half of the things I wanted to say, he already said. So perfect. I will be on time. I will be early. So my anesthesiologist won't bite me once I get to the OR. So I can start if it's okay with you. If you see my screen?
Yes, we do. Please.
Okay, perfect. So when we say when we say to our residents and go put back the bone of that patient, we are actually telling them to perform the most risky intervention in terms of complications that we have in neurosurgery. So if we look at the rate of cranioplasty and complications, it's across multiple studies. It's a huge statistic, and it's from 10% to 41% of rate of complication. So the rationale we have to tell ourselves, I think, is that we need to plan cranioplasty early on when we first do the craniotomy, because half of the complications of the craniotomy are preventable with a good planning, even though it's a traumatic moment both for the patient and for the family and the surgeons. But if we plan accurately the intervention and we perform scalp incisions correctly and we plan ahead, many, I believe, of the complications of cranioplasty, so later on, can be a little, not prevented, but a little at least made better. So we know that we aim to restore the stasis of the patient. We want to improve his dynamics and provide cerebral protection. And also we know that it's putting the bone back will facilitate rehabilitation and probably also enhance rehabilitation because of what happens with the trafficking syndrome and what we see with patients with a good outcome after we put bone back. I think you're familiar with this classification. If not, I suggest you incorporate in your practice. If you want to do research, it's very useful. It's very simple. So this is Clavier-Dindo classification. It will simply state the event of a complication in the first 30 days after a surgery and whether or not there is a complication still going on at the time of discharge. This is useful for all surgeries, but I think it's particularly useful for us because we have usually complications that might last not so many days in our intervention, so transit deficits or else. But in cranioplasty, complications needs to be divided in very early complication and later complication, and also with those with medical management and those that will require surgical management. Not all the complications will require surgical management, but if they don't require surgical management, they are the ones with worse prognosis. The main complications we see are hemorrhage and infarctions, infections, CSF disturbances, fundations, and bone flap resorption. So all those complications we knew very, very well. I am not here to tell you that we will have some hemorrhage after a cranioplasty, that it might have infections. We all know that. The point is that we need guidance. The whole world needs guidance, because we have many controversies about cranioplasty, at least as much as we have about decompressive craniectomy. So what do we do when we have to deal with these kind of complications? Failure to prepare is preparing to fail. So we need to address our issues by reviewing our casuistics and to see what can be done better. When we did this here, we changed drains basically, and it lessened the hemorrhagic complications by a whole 30% of the total. So review your casuistics and think about kind of antibiotherapy, and talk with it about it with your infectious disease specialist. CSF disturbances, if you want to shunt the patient, be sure, if possible, to have programmable valves, which are not very expensive right now. So think about this as well. Fundations, this is also nutritional. This is not just ischemic patients. It's also providing patients with basic nutritional support, vitamins, and also pre-plan the wound incision. So if you do a large flap, as we have to, we are doing a decompressive, to pre-plan the reconstruction later. And about bone flap resorption, I'll talk about it later, but the risk factor for complications, they are predictors of overall complications. Of course, if we have a patient with hypertension, with elderly, and with an hemorrhagic stroke, it will predict a major rate of complications. And while predictors of mortality are underlying disease already present, and the bifrontal cranioplasty, and also repeated hematomatic evacuation. Why I'm talking about bone flap resorption? Because one of the queries in literature is, what do I put back? And the answer is usually what I will put back what I can. Usually, we cannot state that autologous bone is better or worse than prosthesis, but bone flap resorption is a specific material-related complication. The etiology may be quite variable, and infection, underlying infection, lack of blood supply, also here nutritional. It will bring a high rate of surgical redo and moreover infection, and you will have a failure of the protection issue that you want, the reason you want to put back. So it's not demonstrated that subcutaneous or biobanking will bring different kind of rate of bone flap resorption, but we know that younger age, meaning younger and more vital metabolism, shunt dependency, and fragmentation from trauma are independent risk factors for bone flap resorption. So also other things that we have to consider is that materials about cranioplasty and methods of the cranioplasty. It's better early, it's better late, it's better autologous or not, it's better in the very beginning, it's better after a little bit of rehabilitation, whenever rehabilitation is present, but it's not said. There is my whole goal is to talk about this consensus statement, which is amazing, and it's a very it's made it's 3 years ago in Naples, with a wide variety of nationalities present in the committee and in the others. So this needs glasses, but it's an open access paper, and I suggest to everyone to read it and to have a look. It's based of eminent opinions, and I think it has helped my practice a lot. I was still resident when this paper came out, and I'm application cranioplasty as something that will occur, that we pre-plan this with our patients and mostly the families. But even so, even when we're thinking about complications, when we're talking to families before performing a decompressive craniectomy, we already tell them there will be a second surgery if your loved one will manage to stay alive. So it's a plan. And I think this is all we need to convey. There might be complications. We can manage them. They can be burdensome, but it's a plan. So we're doing everything we can from the moment of the compressive craniectomy to the cranioplasty. And the family, from my practice, the family has a much more acceptance of the second intervention and the possible complication that will arise if they know that their doctors, their beloved doctors, is planning for them and with them. So this is my bibliography for this kind of talk, and thank you very much.
Thank you very much, Laura, for an excellent informative talk. I think it's very important for the young neurosurgeons to understand that cranioplasty is very important to restore the function, and it's not just for cosmetics. So people should understand that. And I think the C3 consensus meeting in Naples by Corrado e Carano dealt with a lot of questions. And if you want to look up that paper, that will show you exactly regarding when to do it, because timing again is very important. We all know that if you store the bone flap in the subcutaneous tissue as we normally do here and not in a bone bank, then the resorption rate is very high and you don't want to do it earlier on than that. So any questions, comments from anybody, please, for Dr. Laura Lipa? Your anesthetist is waiting as well, I think, Laura.
Laura, thank you very much. Very nice talk on a subject which most people don't pay too much attention to, but the patient's already severely impaired and the family's at their wits' end because of what they've been through, and then there's complications from the cranioplasty. It's a scenario made in hell. The question I wanted to ask you was, so obviously you do autologous when you can, but if you have to get a synthetic, have you had experience with the 3D printed, purpose-made implants, which I've had one opportunity, and I'm very impressed by how nicely they fit and how good they are. Have you had that experience?
Yes. So most of the time here we order 3D printed based on the CT scan, on the volumetric CT scan of the patient. So before, we have a kind of protocol. So before, like 3 weeks before the planned intervention, when the patient is already stable and without infection, we do the CT scan and we send it to the industry that will send us back a couple. So there is one of reserve. A couple of implants, they fit perfectly. Usually you have to do a nice fixation of the bone, and you take all the tissue away, because the CT scan it's really a puzzle, and it's very well made. Up till now, we don't have, with this new industry, it's ceramic and then methyl methacrylate as well. The fact that we can also store them with antibiotics if we want, so we just have to tell them for a long providing of antibiotic therapy. If there was some kind of infection or we plan that the patient will occur some other infection again. But yeah, we use autologous when we can, as much as we can. we don't use autologous when there is bone fragmentation, because we've seen that the resorption is higher and the infection is higher, even though we store them in the biobone, it's a freezer. So yes, they fit nicely.
Thank you. Any other comments, questions? No. Okay, thank you very much, Laura. We'll let you go and do your surgeries. We are very grateful. Thank you for waiting for so long for this
Thank you.
thing. Hope to see you sometime soon.
Hopefully.
Face to face.
Thank you very much.
Thank you.
We are thankful to the foreign speakers. And now the talk is on the management of thoracolumbar trauma by Dr. Shehzad Shamim from AKU.
It's better. Assalamu alaikum, and thank you for the organizers for inviting me. I'm going to deviate a little bit from the topic in the program. I'm going to talk about the controversies in the management of thoracolumbar trauma, so it fits with the rest of the speakers. Yeah. Okay, so the slides are not changing here. I have no conflict of interest. Right, I have a few limitations to my talk. Firstly, my talk will only be addressed on adult patients. I will only be able to address a few topics because of the interest in time. Also because of the interest of time, I am limiting my references to a limit because, I mean, this talk can go on for hours. And of course, it will only be a 10-minute talk. I will, being a neurosurgeon, I will put in my personal views and preferences, which may not be globally applicable, not just for each individual center, but also for each individual surgeon. So the first controversy that comes to mind is the classification. And we read a lot of classification system for thoracolumbar trauma. We tend to use the TLICS, and this is what is frequently told to us by the people appearing in the examination. So it seems that for neurosurgeons around the country, this is the most frequently used classification system. It is easy to use, and it also has a row in the bottom which sort of guides a surgeon to operative or non-operative management. But if you look at the literature, it's not the best classification system. It does not have good inter-observer variability. It's not duplicable, and there are lots of problems with that. And on the other hand, the AO spine classification for thoracolumbar fractures seem to fit the bill better than the TLICS classification system. And just recently, there's been a consensus on this that the best classification system for thoracolumbar fractures is still the AO spine classification. The second controversy I'm going to talk about is the role of steroids. And to be honest, there's not much controversy in that. We all know that the NASIS trials, we all know what came out of it. However, we still see a lot of patients being managed around the country with steroids in the initial phase. So just a recap, this is the famous, the hype cycle that has been introduced by innovators, the company Gartner, and is applicable to a lot of new innovations that is introduced in the market, be it implants, be it technology. And this is what typically happens whenever something is introduced. Everybody starts using it, and then the data starts coming in, and the use slowly fades. And so this has been the trend with the use of steroids in spinal cord injuries as well. The use was immense at the time that the first NASIS paper was published, and then the post hoc analysis was published, and the commentaries came in, and then discussions and debates came up, and all of a sudden the use went down. We now see some use around the globe, but there have been a number of studies where the surgeons were asked, do you use steroids or not? And interestingly, most surgeons prescribe it, but most surgeons believe that it does not work. So the data that we have right now, if I am to summarize it, the steroids for spinal cord injury have questionable benefits. They have definite side effects. And still the data is unclear with regards to the dose, the duration, and the type of steroids that are to be administered. My next controversy I'm going to talk about is non-surgical versus surgical management. When I started my training, I was a very proponent of managing spinal injury without surgery, especially patients with complete spinal injury, because we found out at our centers that patients with complete injury tend to have worse complications, higher cost, and the outcomes were no different. In fact, our outcomes were worse than patients who were managed with surgery, without surgery. So based on that, we recommended that for patients with complete injury, we should not be operating. However, we faced a lot of wrath for that paper. Also, when I look back at my study, very few patients that I found were actually for thoracolumbar fractures. It worked well for cervical spine injuries, but not so well for thoracolumbar fractures. By and large, the consensus is this: regardless of the extent of injury, regardless of the neurological status, patients with unstable spine should be fixed. Now the question is when to fix it and how to fix it. We'll talk about it later. But generally, there's one specific type of spinal fracture on which there's more of a controversy and whether they should be fixed or not, and that is the burst fracture. And there are several trials, several randomized controlled trials that have looked on it, and they're not very high-powered trial or very good randomization, but the consensus generally is that operative management of thoracolumbar burst fractures without deficits may improve kyphosis, but does not appear to improve pain or function at an average of 4 years after fixation. So the results are the same, whether you fix them or not fix them. Of course, as clinicians managing these patients on an individual basis, in these circumstances, it's up to us on how we would like to tailor our decision based on that patient and the circumstances. But that's what the data says so far. Now, the timing of surgery for thoracolumbar fractures. So there are lots of studies on this as well. And this is a recent systematic review which has really looked at how the timing affects the outcome of these patients. But if I'm to summarize, it is preferable that these patients, so if you have a thoracolumbar fracture that needs to be fixed, it's preferable that you do it within the first 72 hours. However, if the patient has additional injuries or the patient is unstable, it's safe to wait beyond 72 hours. The earlier papers all talked about improved outcomes if you fix early, that is within 72 hours. However, there are two recent papers published in the last 5 years that have talked about the second head phenomena, and that is, patient is just coming out of a physiological injury and you subject them to another physiological injury, and that's what they call the second head. And they showed that the outcomes in these patients, the medical complications in these patients were higher. So if you do proceed with fixation within the first 72 hours, there's a small risk that these patients will have a higher risk of medical complications. So again, the data isn't clear, and the decision rests on the operating physician, operating surgeon. That's one of the two papers that talked about the double hit. The next list of controversies I'm going to talk about is surgical approaches plus. This includes not just surgical approaches, but other factors that we deal with. So there's a lot of debate on whether these fractures should be fixed from the back, from the front, both from the front or the back. There's immense amount of data that shows that posterior only fixation is good enough for most thoracolumbar fractures. In my personal practice in the last 6 years, I have not had to do a posterior fixation from the front. I do it almost always, now I do it always from the back. And I think all sorts of fractures can be reduced from the back. It saves time, it's quick, it's less traumatic, especially for patients with systemic injuries. So it works well. There's a controversy with regards to using short segment versus long segment fixation. Again, the data clearly shows that there's no difference for certain types of patients. But with patients with increased scaffolding deformity, you would like to do a long segment fixation. But if there's not a lot of scaffolding deformity, you can go ahead with a short segment fixation. There's some debate about using the fracture segment for fixation. As you can see from this patient, I try to put in screws in the fracture segment whenever I can. The recent data shows that you can. In fact, at times, even if you are 3 millimeter, 30 millimeter length pedicle screw, that's good enough, because as long as you have purchase of the pedicles, that still provides some stability. So whenever you can use the fracture fragment, it's preferable. But if there's a fractured vertebral body in front of the fracture, and there's a risk that your screw placement might push the fracture fragment onto the retroperitoneum, it's better not to do it. So the data is divided, but it has to be individualized according to each patient. MIS versus open, not a lot of papers, but it seems that MIS should have better outcomes in these sort of patients for a lot of reasons, and some of these reasons I'll allude to further on. Polyaxial versus monoaxial, again, there's not a lot of difference, but whenever there's a correction that has to be made, monoaxial screws are probably better. I always use polyaxial screws. And then there's a lot of literature about the length and the diameter of the screws. Again, the fundamental principles are that the screw length should not be less than half the breadth of the vertebral body. Longer length screws have been shown in some studies to offer greater stability, but there's no comparison, so we can't be sure that this is it. And these are mostly cadaveric studies with small sample sizes. The principles are you need to have a length at least more than half the depth of the diameter of the vertebral body. If it goes up to 2/3, that's even better. Diameter of the screws, there are several studies also on cadavers which have talked about this, and generally a larger diameter screw offers better stability. My personal practice is I would not use a less than 6.5 millimeter diameter screw in a thoracolumbar fracture, even in the thoracic spine. Again, lots of debate about whether these fractures should be fused or not. The data is conclusive here. Adding additional fusion material does not add to fusion in thoracolumbar fractures. Remember from orthopedic principles that this is an internal fixation. It does not require bone grafts. The fracture, as long as you're able to stabilize the fracture, immobilize it, the fracture will fuse itself. But if there's additional bone loss, it might be worth it to put in some bone fragments. So as far as the data is concerned, the literature is concerned, we don't need to fuse these fractures, we only need to fix them. Initial studies talked about using the different types of grafts and BMP. The choice of grafts does not help because now we know that fusion does not add to the stability. Similarly, BMP does not help. In fact, there's some studies which talked about BMP offering better fusion. However, it's not cost effective, even from the standards of the West. And precisely for this reason, that the type of grafts and fusion does not add to the stability, that we feel that MIS would be a superior choice for thoracolumbar fractures than doing it open. Antibiotics, I mean, there's tons of data that shows that antibiotics in closed clean surgeries beyond the first 24 hours do not add to any prevention of infections. But we keep seeing these patients put on long durations of antibiotics with broad spectrum antibiotics. But there is inconclusive data, irrefutable evidence that antibiotic prophylaxis beyond 24 hours of a single dose covering gram-positive staph will not offer additional benefit to these patients, as long as these are clean surgeries. And that was my last slide. Thank you.
Thank you very much, Dr. Shahzad, and you have highlighted the many points regarding this topic. So any question, any comments regarding the topic from Dr. Shahzad?
I think there's a lot of generalization here. You cannot equate thoracic fractures and lumbar fractures. I mean, you can decompress lumbar fractures from behind, putting in pedicle, but for thoracic fractures with a significant compression from the front, especially if you've got a partial neurological deficit, it's always safe to go from front, decompress and fix from the front. A lot of spinal fixation and spinal work is being done by the orthopedic surgeons, and they are actually scared of the neurological structures, and they've always advocated going from behind, putting in screws, and they always say they get better results. But those neurosurgeons who have been practicing operating from the front, decompressing and fixing, quite a few of us have been doing that. They find it's much safer to do it from the front, especially in the thoracic spine where you're dealing with the cord. So it would be safer to go from the front, decompress, maybe fix from the front as well. And even if you want to fix from the behind, just decompress and then roll back and fix from the behind, but decompress from the front.
Any other question? I have a comment. When we were trained, there was, as Dr. Junaid also said, that we were trained from also the anterolateral approaches. But nowadays, most of the residents are doing from the posterior approach. So there is a flaw here that these neurosurgeons are not knowing how to go anterolaterally, and most of the time they avoid and go posteriorly. As Dr. Junaid said, whenever there is a compression from the anterior side, you have to decompress it from the anteriorly. And whenever there is no need and only the biomechanics comes, and we have to fix the spine, so we can go from posterior. But as we are discussing on the other cranial issues, we should know about the every surgery, like the endoscopic and also the transcallosal. So again, in the spine, I think a neurosurgeon or a resident should know about how to go anteriorly and decompress it, either thoracotomy at the thoracolumbar region or retroperitoneal.
So, Dr. Raja, I completely agree that all surgeons, all neurosurgeons, or even all spine surgeons need to be familiar with anterior approaches, and we are training our residents to be familiar with them. But I don't agree that it's the best approach, especially in trauma. If you look at the biomechanics, for a patient to have a strictly thoracic trauma with the anterior collapse, this will be an injury involving blunt force on the back. Most of these patients have thoracolumbar fractures, not thoracic fractures per se, but and even for strict thoracic fractures, patients with no deficits, it's unusual to have patients with that degree of trauma and no fractures. But as I said, there's hardly a case where you can't not just fix them from the back, reduce the fracture from the back, but also decompress from the back. And there are many techniques to do it. And the reason why I choose not to go from the front is that I feel, and I may be wrong here, that adding a thoracotomy or a retroperitoneal approach in a trauma patient in the first few hours, in the first few days, may look good on the post-op X-ray, but may not be the best for the systemic management of the patient. But of course, this is how I practice. It's an opinion. It's not a fact.
Can I say something? As Professor Junaid said, front and decompression from the ventral surface is quite a hectic job as far as thoracotomy is concerned as compared to the posterior approach. But frankly, the anterior approach is quite safer in another way. In trauma, most of the time we usually encounter with the dural leakage, CSF leakage, and anteriorly when you do anterior decompression, thoracic cavity has got an ample amount of space to accommodate that CSF leakage. But in posterior approach, if you do a laminectomy and a fixation, then definitely there is a possible chance of CSF leakage, which is very difficult to deal at some time, and you may lose the patient. So definitely there are some pros and cons. I think this need another long time to understand the actual way to do it. But I think we have to keep doing both these procedures to understand the actual, all the fractures behave differently. Thank you.
Well, thank you. I think we should conclude this session now. Thanks to all the speakers, foreign and local, and thanks very much.
Thank you, Dr. Riaz Raja, Dr. Atiq Ahmed Khan, and Dr. Tariq Khan for facilitating this session for us. Now we are going to have a 40-minute break for lunch and prayer. We will be resuming our sessions after 2:30 sharp. So I would request everyone to please proceed to the exhibition area for lunch, and I request them all to please come back here at 2:30 p.m. sharp. Thank you.
Assalamu alaikum. We're gonna continue our sessions of oral abstract presentations. There were 2 left, so we'll continue with that till all the people arrive. And we have our moderators, Dr. Raza Rizvi and Dr. Amir Sagir. Can we have them on stage, please? Do we have Dr. Raza Rizvi here? Thank you so much. We're gonna start our presentations. The next presenter is Dr. Muhammad Usman from FJMU College, Lahore, and he's gonna present outcome of anterior cervical discectomy and fusion with standalone in cervical degenerative diseases. Do we have Muhammad Usman here? Please welcome Dr. Muhammad Usman on stage.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Muhammad Usman Anwar. I am resident of neurosurgery at Fatma Jinnah Medical University, Sir Gangaram Hospital, Lahore. Today I am going to present outcome of anterior cervical discectomy and fusion with stand-alone peak cage in cervical degenerative diseases. First of all, degenerative spinal diseases includes disc desiccation, decreased height, herniation, and instability at the motion segment. Disease burden is 25% individuals under the age of 40, 50% of individuals over the age of 40, and 85% over the age of 60. So more incidence is in the old age. Goals of surgery are effective neural decompression, spinal stability, and sagittal balance. Coming to the management. First of all, it's conservative. We try to treat the patient conservatively. If the conservative management fails, then we go for the surgical approach. Coming to the surgical approaches, there are 2 main approaches, fusion and fixation, and second one is the motion preserving surgery. Fusion and fixation include clovered approach, which includes tricortical graft. Hirsch, then Robin and Smith, which include bicortical graft, and the last one is Hirsch, which include no graft. Fusion can be done with different sorts of grafts. It includes allograft, autograft, xenograft, and peak cage. ACDF with and without anterior cervical plating can be done. While motion preserving surgery, artificial disc is placed, which is called arthroplasty. Type of grafts used are bone, non-metallic, and metallic. In this study, after trial of conservative treatment for surgical management, anterior cervical discectomy with peak cage assisted fusion without any cervical plating was performed. What are the disadvantages of plating? Need of screw placement, which compromises integrity and stability of vertebral body. Basically, there are 3 post-op also complications, which include the biomechanical complications, tracheoesophageal complications, and first the main is wrong placement of the screws. Questions are, is plating actually required in degenerative spinal diseases? Can ACDF without plating give adequate interbody fusion? Objective of the study. Objective of the study was to evaluate the efficacy of peak cage in ACDF without plating in terms of improvement in symptomatology, rates of subsidence, and postoperative complications. It was a retrospective case series, duration of 1.5 years. From January 2020 till today, 21 cases were included in the study, 13 were males and 8 were female. It was done in all department of neurosurgery, Sir Gangaram Hospital, Lahore. Inclusion criteria include patient having cervical degenerative diseases of both genders between age of 28 to 60 years. While patients which were excluded were having cervical trauma, infection, malignancy, and previous spinal injury or surgery. The post-operative clinical and radical data for patients who underwent anterior cervical discectomy and fusion with peak kgs for degenerative cervical disc disease without plate fixation. Improvement in neurological status and post-op complications were noted at immediate post-op day, after 48 hours, and after the 6 weeks. These are some MRI showing disc in the different levels. These are the sagittal section, and these are the axial section showing the disc. Procedure to do discectomy was anterior cervical discectomy, ACDF. Syncrease incision, transverse incision was given, platysma cut, carotid sheath and lateral carotid sheath laterally at trachea, and esophagus retracted midly. Clover detector applied to retract the longus colli muscles. Microscope was applied. After confirming the level with C-arm, discectomy was done. Bony osteophytes removed and end plates prepared with high-speed drill diamond burr. And posterior longitudinal ligament was given an incision with blade 11. Peak cage with bone dust filling was placed. Wound closed in reverse order. These are on the left side, there are the phantoms for sizing, and on the right side, these are the peak cages. And the bone dust is filled in these peak cages before the placement. This is the image after placing the peak cage. We used to do the cervical plating 3 or 4 years back, but now we are only doing the peak cage without cervical plating. These are the images with cervical plating. These are the results or after post-op x-rays of our patient with peak cage placement. Coming to the involvement of disc level, the most of the time the disc involved was C5 and C6 level, and the least was C3 and C4. Complication seen in these patients, only one patient shows dysphagia and only one patient has subsidence. So coming to the results, total number were 21, 13 were male and 13 were male and 8 were female between the age of 28 to 60 years. 16 had radiculopathy and 5 had myelopathy radiculopathy. 16 had the single level disease while 5 had the adjacent level disease. Improvement of radiculopathy was seen in 16 patients, while improvement of myelopathy 4 out of 5 patients, which upgraded the MRC grading by 1 grade. Subsidence occurred only in 1 patient who underwent the adjacent level surgery. Coming to the conclusion, use of peak cage alone as disc substitute in ACDF for degenerative cervical spinal disease is associated with better spinal alignment, achieving adequate disc height and interbody fusion. Low incidence of post-operative complications like dysphagia, subsidence after 3 months post-operatively, and has advantage of absence of donor side morbidity, infection at the donor side. Thank you.
Thank you so much. Moving forwards, we have the spine session. For that, we're going to call on stage Chairperson Dr. Sajid Nazir Bhatti, Co-Chairperson. Okay, Dr. Lal Rahman is. Can we have Dr. Lal Rahman on stage, please? Yes, Dr. Lal Rahman is going to present ethical dilemma in lumbar disc surgery.
Bismillahirrahmanirrahim. The topic which has been given to me that is somewhat different from the other presentations. We have learned a lot about the surgical skills and we will learn, but this topic is to know about the ethical dilemma. So it is a very easy topic as well as difficult topic. Easy in the sense that we can discuss it very easily, but difficult in the sense that to follow the ethical rules, that is difficult. So what is ethics? The word ethics is derived from the Greek word ethos, which means character. So to put it formally, ethics is the branch of philosophy that defines what is good for the individual and for the society and establishes the nature of obligations or duties that people owe themselves and one another. So what is ethical dilemma? It is also called moral dilemma, and it is a problem in the decision-making process between two possible options, neither of which is absolutely acceptable from an ethical perspective. It means that if a patient is having lumbar disc surgery, lumbar disc herniation, so there are many options. Either the patient will need conservative treatment or surgical treatment. And all of these are the options. But here we should decide, and this is very difficult, and we should decide that what should be done, whether he needs surgery or whether he doesn't need surgery. If he needs surgery, he should be operated. If not, he should be managed conservatively. So this is very important that we should select the option which is good for the patient. And we should follow these principles because the main purpose of our managing this patient is to give benefit to the patients. And there are certain principles, without knowing this principle, without following these principles, managing this patient, that is not ethical. So the first one is the respect for autonomy. So the patient should be explained about this disease. Whether the patient is having lumbar disc herniation, he should be explained each and everything. And now the patient should be given the opportunity, and that is he or she who decides whether she or he accepts your treatment or not. So there, the patient should be free in his decision. And the other important thing is that beneficence, what we do, what we have decided, what option we are giving them, that should be beneficial for the patient. So we should decide in the best interest of the patient. And the third important principle is non-maleficence. In what we do, what we have decided, that should not harm the patient. And the other important principle is justice. So there should be fairness and equality. So these are the main principles which we should follow. So our main purpose is to give benefit to the patient. And for that, we should decide properly whether from the option which I'm going to offer, whether the patient will get benefit from the surgery or not, and whether this patient is candidate of surgery or not. So sometimes when a patient is having pain, there is herniation, but the clinical findings are not correlating with the MR findings. So we should always keep these things in mind, and the decision should not be in our own interest, that should be in the interest of the patient. The ethical dilemma, what we do, that is legal or illegal. So if we are following these principles, that is legal. If we are not following these principles, that is illegal. There are many things. You see that nowadays, most of the people, they insert screws. So we should decide whether my patient needs screw or not. If not, don't do it. If yes, then we can do it. The other thing is that whether this patient needs surgery or not. If a patient is having pain, there are many options. Physiotherapy, there are medicines. So we should follow all the things which are important, and the decision should be, again, I'm repeating these things again and again, and the main purpose of my presentation is to decide what is good for the patient. This presentation is slightly different from the other presentations because we are not discussing the skills, we are not showing the papers, we are just discussing the ethics. Now, there are some important questions one should ask himself. Should we operate the patient of lumbar disc herniation or manage him conservatively? And I think each and everyone knows whether my patient needs surgery or not. So we are the best judge, and we should do what is good for the patient. And we should know when not to operate. It is very easy to operate, but we should know when not to operate, and we should always follow the rules, that is autonomy, beneficence, non-maleficence, justice, and cost awareness. We should know about the cost, because if a patient does not need surgery and we go for surgical intervention, you know that he has to pay. And most of our patients are very poor. So we should know about these factors. So we should always be conscious about the cost. Now, what is the problem when we don't follow these ethical principles? So what happens? There is increase in the number of unnecessary radiological investigations. And there is unnecessary increase in the number of surgeries for persistent lower back pain. So when a patient comes to us, we should properly take history, we should properly examine the patient, and we should decide whether this patient needs MRI, yes or no. Most of the patients, they don't need MRI. Why should we go for these investigations? So we should also concentrate on our clinical skills, which are very, very important. And then after that, if the patient needs, yes, then we can go for that. If not, we should not do unnecessary investigations. Why there is increase in surgeries? Patients are not told about every treatment options available. So whenever a patient comes to us, we straight away go for surgery. No, we should tell them that there are other options as well. We can manage them conservatively if the desk is small. We can go for physiotherapy, we can go for conservative management. And when these options fail, then yes, we can go for surgery if there is significant herniation. And there is also social misconception that surgery should be done and the pain is relieved early. So I think the facts should be explained to the patients. Ultimately, this is our fault. So some of us do not follow the basic rules of ethics. We don't tell patients everything. And patient cannot make autonomous decisions. We don't care about the cost that the patient will have to bear. The most important rule for a surgeon is to know when not to operate. So I'm repeating all these things again and again, and the main purpose is that we should explain all the things to the patient. Patient should be free in his decision. And if I'm sure that, yes, my decision is good for him, then okay. If I'm not sure or if that is not good, we should not decide accordingly. So when a patient comes with lower back pain, it is not an indication of MRI and it is not an indication of surgery. Take history, examine the patient. And most of our patients, they don't need these things. Just give them painkillers, or advise them physiotherapy, and most of them, they give good results. Evaluate the pain and see if the patient needs MRI. If MR shows lumbar disc herniation, it does not mean that the patient needs surgery. So always we should correlate the clinical finding with MR finding. We should not treat the MRI, we should treat the patients. And nowadays, it is also a common practice that most of the people, they have their own MR and other things. So it has been seen that those surgeons who have their own MR, the likelihood of spinal surgeries increased by 34%. So this is also a very important factor. So we should not be money makers. And all we know that there are certain indications. If there are clear-cut indication where lumbar disc is herniated and there are clear-cut indication, we should go for surgery. If not, we should avoid. So these are the indications which I have mentioned. And we see that most of our patients, they give good results when we manage them conservatively. But yes, if there is cardiac syndrome, when there is deficit, when the patient is not responding to these things and there is significant risk, we can go for surgery. If not, we should also follow the conservative management. Now, the important factors. You see that there are three important factors. One is the surgeon, other the radiology, and the patient. So we should know, and it is must that whether this patient needs surgery or not. If yes, if the patient needs surgery, then whether I can do this patient, I can operate this patient properly, yes or no. You see that when there is a patient with the lumbar herniation on one side, then why should we go for laminectomy? Why not for microdiscectomy? Why not for fenestration? When a patient does not need fixation, then why should we go for extra screw fixation when there is only the patient can relieve with only discectomy? So these things should be kept in mind. And as I mentioned, we should manage the patient, not the MRI. And the other important thing is that when we operate these patients and the patient is still complaining of pain, so don't send them home. These patients should be, now you have operated, I think we should go for MRI. If there is disc, we have not removed completely, then we can go for redo surgery. So most of the people I have seen that they send the patient home on medication and say that you will be okay. Why? You should do it properly. And we should accept the complication. If you have done, you should own the patient. There is a patient, you see that this patient has been operated and post-operatively there's still this. So how can we know that we should, if my patient has actually, still he's complaining of pain, I should go for MRI. If there is this, I should go for redo surgery again at that time. I should not wait for whether the patient will relieve with medication later, or whether there will be more cost and I will get less benefit. That should not be kept in mind. So what can we do? So it is very important that in addition to teaching about the skills, about the different things, we should also teach about the ethics. And this teaching should be at the medical college level, and this should be in the training as well. And we should always be honest, and we should tell truth to the patients. And we should not perform unnecessary surgeries. That is very important because the patient can be relieved with the medication, but when we go for surgical intervention, you're cutting his back, you're cutting his bones. So why should we do it? And we should also keep in mind the conservative treatment. That is also very important for us. And again, I will review that we should follow these principles, that what we do, that should be in the benefit of the patient. We should not give any harm to the patient. The patient should be free in his decision. This is he or she who can say whether I should go for surgery or not. And anything should be done, that justice should be kept in mind. So our facilities or all things should be equally distributed, and our indication should be equally. And the other thing which is not here, that is the cost awareness. We should know about that. Thank you. This topic was a little bit different from the other topics. Thank you. Thank you. Yes, sir.
I need to stand up. Lal, thank you so much. And we meet quite a lot and we talk, but we talk technical things and specific things, and we don't really look at the larger picture as you have. And this is really quite important. But there's two things that come to my mind, which play into what you're saying. And one is that we really should be weighing up cost options to offer the patient. Like, for instance, we've had two presentations today, both extremely effective in their treatments. One, peak cage, 16 patients with radiculopathy, all got well. But at the same time, Dr. Kharal from DG Khan tells us that all you need to do is make a little hole in the back, and those same 16 patients would also get better. So we really need to be weighing up of that. I'm not saying which is better. I'm just saying we need to be weighing up and bring cost efficiency into the thing. And the reason that's important for us, it may take a little time, but Lal, you know that increasingly across the country, third-party players, which is payers, which is the government, their Sehat cards and their Insaf cards, and those schemes are coming into play. So people are going to be paying for their surgery out of these schemes. And then the schemes will start asking you questions that how come those 16 patients who had radiculopathy were operated with a charge of so much, and the same 16 in DG Khan were. So that's why it becomes important.
Yes.
And I think that so we really should be thinking more and more along those lines.
Yes.
But I just want to leave you with a question. And my question to you is, do you think that ethical behavior or ethical practice is something that is inherent in the individual, or it can be taught by example and apprenticeship in the way that we do?
I think both, in both ways, it can be inherited as well, and it should be taught as well. So we should have a practice of this, and we should be aware about these things. So we should all know about the ethics, and we should be aware. I think most of the people, they are good people, good surgeons, but we should be conscious about the ethical issues. Thank you.
Thank you so much, Dr. Lal Rahman. Now, Dr. Amir Sagir, thank you so much. Dr. Raza Rizvi, thank you so much. Now, we're going to proceed towards our last session, that is Bashir Ahmed Memorial Session. And can we have chairperson Dr. Anjum Habib Vora, and can Dr. Abid as a moderator join us on the stage, please? The presenter for today is Dr. Hassan Bari. He's going to talk on medulloblastoma, the way forward. Please welcome Dr. Hassan Bari.
Assalamu alaikum. Thank you very much. Badi der kar di mehma aate aate. But last but not the least, I'm honored to be presenting this Dr. Bashir Memorial's lecture. Dr. Bashir, you probably don't know him. When I was very young in Lahore, I remembered him well. He was more famous than most of the cricketer, or his name transcended all the people. He was as famous as a character or any celebrity. So before further ado, we start my lecture. It's only for 15 minutes. Medulloblastoma. Everybody knows about medulloblastoma, this undifferentiated small cell tumor arising from the cerebral neuroectodermal. It is one of the most frequent tumor in the childhood, especially, and it's the most malignant at the time. 20% of the childhood tumors are solid tumor is medulloblastoma, and at many times they do metastasis, and at times they present with metastasis. Now, at this present time, most of the classifications are morphological classification based on histology. We have 4 types of different grades. One is classic medulloblastoma, desmoplastic, nodular, diffusely nodular, medulloblastoma with extensive nodularity, and large cell anaplastic time. But as the world is changing, there is more based on these. On the clinical factors and on the basis of morphological studies, we have done the risk stratification and prognostication was done. It was based on clinical factors, age. Younger the age, the more malignant it is, was considered. Extent of resection, we will come back to that, whether it's total, near total, or subtotal resection, or it was location posterior fossa metastasis, whether there is a CSF positive. Histology, diffuse classic is known as less malignant than as compared to the large cell anaplastic time. So based on these factors, the risk stratification was done, and it was done into an average risk stratification and the high risk. High risk was those people who has less morbidity, less than 50% chance of surviving for 5 years. Now, more and more transcriptomal studies are coming and molecular-based studies are coming. And before we go on to those studies, we will say this, with all this thing, if you look at this chart in 1970, there was only a 50% chance of survival of a child. And as it's coming up into 2000, 2005, there's 70 to 80% of the people do survive for more than 5 years with all the new medication and the treatment. Now, there is a chance that people may die of the complication of clinical radiation and toxic chemotherapy, then of the certain types of medulloblastoma. So we have to be very careful about what we are treating, how we are treating, what is the type of medulloblastoma. Now, what's happening is that with this morphological transcriptional studies, now, there was a consensus meeting in 2005 in Boston, which they have further subclassified medulloblastoma into 4 further types. Now, it can be subclassified too, but at this, the consensus was that there are 4 was based on. One was WNT, second was Saunage hedgehog type, third was because they were not able to classify it, they said it's 3 group or a 4 group. Now, these are based on the demographic or also on the, if you look at the WNT group, the most common finding was that there was a loss of chromosome 6, and there was a proliferation of MYC proteins, and it was named after because this won't groups there was a pathways, and because of the problems was coming in this way pathway, and because of such trisomy 6, this pathway was affected, and on all those groups which this pathway was affected was producing this one group. That's why it was named as WNT. And the same thing was for the sonic hedgehog. This was also a pathway in which the PTC receptors and the germline things were affected. There was, in this group, if you look at it, there was the trisomy 9q, 10q, and 3q was there, and there was the proliferation of MYC and proteins. Now, and the third was, which is considered to be group 3 is the most malignant one. Most of the time, if you look at it, the classic histology, there was large cell anaplastic type of the tumor. These are the one they metastasize much more commonly. They are more often seen in the infant age group, less than 3-year age group. And while the group 4, which is considered to be of intermediate risk, is more in adults. And it's also at the pathology, the old pathology, if you look at old pathology, they are more classic and LCA were more or less of the same group. And in this, there was the specific thing that there was a loss of 11p or the gain of 1 chromosome, and in which there was also a MYC protein proliferation. And they were also, because this, they were also the biomarkers and immunostaining assays were further done. And in WNT group, there was this beta catenin that was seen. And for describing any one group, you have to have at least 2 or 3 things positive to put that, categorize that patient into that group. Now, if we, this the next slide is more or less the same thing. It's telling the bone group has a better outcome. The pattern of relapse is much more local in the Wnt group. And if you look at in group 3 and group 4, when the patient relapses, it doesn't relapse at the same site. The local relapses are not there, but it's always a metastatic relapse. And probably the different clones are there at the time of relapse than that was present at the first time. So that's why nowadays people are saying if something relapses after 2 years, they should again be biopsied because it might be different than the initial time. Because a lot of radiation was given, usually in the old days, 36 gray of radiation was given to this child. And this child, especially of low-grade medulloblastoma, is much more prone to secondary malignancies rather than the medulloblastoma itself. They are more likely to die because of secondary malignancy than of the group itself. And there are genetic aberrations, there are other aberrations which we have more or less. And why we wanted to classify these tumors on the basis of this molecular pathways. Why? Because they say when there is in one group, if there is one transcriptional problem, one transcriptomic problem, there's one chromosomal problem. The problem is probably all of these groups are going to behave in the same way. And if we are going to have one drug available that can control it, then they would be effective for whole of the group. And nowadays, the studies are coming with gemcitabine, pemidrex. They work against the smooth thin cell, and they are able to delay the relapses, and they are better able to work in anticlonal bodies working in the relapses, and they at times delay the relapses. Now, if you look at this, and based upon these molecular subgroups, there was a group that was the Heidel group that was all of the Neurosurgeons, 45 MAGIC consortium people from the 45 countries who were dealing with medulloblastoma tumors got together and they had a consensus meeting. And based on this consensus meeting, they re-described the stratification and prognosis of all the medulloblastoma. Now, previously it was only described average group, average risk, and the poor risk. Now they are describing low risk, average risk, high risk, and a very poor risk. And if you look at it, in the low risk, we have WNT Wnt group, and we have people of the group 4, which was previously described as the average group. If these are the patients which chromosomal 11 different, they are considered to be a very low risk patient. And should we be giving them the same amount of radiation? Should we be giving them the same amount of chemotherapy? So based on these people, patients who are come in won't and they don't have any metastasis, people in group 4 who don't have any metastasis, and there is a loss of or a gain of one chromosome, they generally behave really well. The rest are coming in, if in the sonic hedgehog group, which was considered to be average prognosis, but people with T53 mutations, these behave very poorly, even if these tumor doesn't metastasize. If the patient has a TP53 mutation, then they're going to behave, their risk is high to a very high risk. So based on all this, now the whole of the treatment paradigm is, there is a paradigm shift in the treatment philosophy. This is the same slide, and this, low risk are the ones which are, which they don't have any metastasis, which is, if you have done a surgery, there is less than 1.5 cubic centimeter of the tumor left. So in such patients, you can do a wait and watch policy rather than giving them high radiation or giving them low radiation of 18 gray or 23 gray. There are 2 trials, PNET 5 and COG trial. They are at this moment looking at this with the low amount of radiation rather than giving the classical radiation. And the chemotherapy we were giving before was cisplatin, CCNU, and vincristine. That too is toxic in the children. We are talking about lessening the chemotherapy too. Now, the COG4 trial, which was seen, which saw a lot of retrospective patients, and saw one of the poor prognostic factor was the poor reading of the MRI scan. People who are treating medulloblastoma should know how on the MRI scan it looks like. Now I just put, this is the classification, biomolecular classification, that's the tumors over there. If you look at this, generally the bone tumors are also at the CP angle is in the cerebellum. Those with the sonic hedgehog type, they are usually cystic and in the cerebellar tissue. And they, if you do look at the enhancement, the contrast enhancement, they homogeneously enhances. There is a solid enhancement. Less than 80 to 90% of these tumor sonic hedgehog type would enhance. And if you look at in the third one, this is the group 3 tumors. Group 3 tumors, they are usually in the middle line, they're in the fourth ventricle, and they enhance patchy enhancement. And these are not a very regular enhancement. The people are talking about rectangle shape, beveled things. And if you look at the fourth slide over there, and that shows it in group 4, these medulloblastoma don't enhance on contrast. They enhance less than 10% of these tumor only enhance on the MRI scan. So this is very important. If you look at it and you can see that if you read it, and also if you are worried about if the tumor is enhancing or not enhancing, before taking the patient to surgery, you wanted to do the MRI of whole the axis of the spine axis to see whether there is any metastasis. If there's a metastasis, you know that the patient has got a poor risk. Now, this slide, number 1 is we want, number 2 is enhancing, solidly enhancing is the sonic hedgehog type. Third is the group 3, and the group 3 is the most malignant, and it comes into a very poor to a poor risk. And the fourth is group 4. Group 4 comes into the intermediate, and there is no enhancement over there. So in future, we are talking about how to reduce the mortality, how to reduce morbidity, and what should we do to increase the understanding of the disease biology. Until unless we don't know the disease biology, we would always be doing a catch-up phenomena. So all we are surgeons over here, we are all interested in what to do about surgery. Naturally, whenever this is there, we have to do resection. Now, how much resection is needed? People are talking about supramaximal resection, but here, all the studies have shown that less than 1.5. Near total to a gross total resection is the same thing. A near total resection is that when you try to remove every bit of it. Gross total is when you try to remove. Near total is even if you maximal safe resection. If you leave 1.5 centimeter of the tumor, near total and gross total resection results are the same. And having said that, this study was done 25 years ago. This is the pre-MRI era study. People are talking about the inherent malignancy of the tumor. Even if the tumor is too large and you think you can't take it out, subtotal resection would be sufficient. But you should not be causing any new onset defects, neurological defect, because this is a patient who has got malignancy is not that bad and he has got a good lifespan, and if you got a neurological deficit, you have got paraplegic, hemiplegic, dyssymetria, so that would cause more problem than what the tumor was doing it for itself. So maximal safe resection without causing any damage to the patient should be our goal. Near total resection is not our goal. Surgical approaches is standard midline occipital one. Here, one of the most dreaded complication is cerebellar mutism. If you want to do medulloblastoma, one should try to do a telovelar approach. Telovelar approach has got less chances of getting cerebellar mutism. It is slightly tedious. You have to go a bit lower and then go to cerebellomedullary junction and then go upward. Look at the tumor from below first and then gradually move upward. But it has the lowest risk. Immediate post-operative constriction is you can have all the complications, dyssymetria, ataxia, rarely low cranial nerve policies, transient cerebellar mutism. But usually these things resolve if you haven't caused any. Other question is, should we do a pre-option? Should we do a post-option? Should we do a EVD? Personally speaking, I never believe in putting a shunt in. No, especially pre-operatively, never. I used to do a lot of EVDs, but nowadays I try to stay away from it too. I wait and do a scan within 24 hours of the patient condition deteriorate, and depending on that, I put an EVD or a shunt. 50% of the people probably wouldn't need it. So, key message over here is that a residual over less than 0.5 centimeter is acceptable. You don't have to take every bit and scrap of it out and cause the patient disability. Avoid pre-op permanent shunt if possible. Use telovelar approach whenever possible, and use all the technologies that is possible. I always believe these technologies always give you help and boost your confidence. QSA, navigation, motor evoked potential, EMGs, everything that's going to, because if you are doing a telovelar approach, you wanted to know 11th and 12th cranial nerves. So motor evoked potential is going to help you. If you are acting the brainstem, you would have auditory evoked potential. So these things give you a lot of confidence, and you are able to do better resection. Coming to our experience, from 2014 to 2020, we have done 36 cases of medulloblastoma. And out of those medulloblastoma, 28 were the boys and 8 were the girls. Though having said the medulloblastoma, there is slight predominance of boys than the girls, but not that much. So that's a bit skewed. 5 of them was less than 3 years of age. 3 of them was, 19 of them was 3 to 10 years of age, and 12 of them was greater than 10, less than 18 years of age. Metastatic at the presentation was 10 of them had metastasis, 26 didn't have it. We did surgery on them. All of our group did. We did gross total resection in 22 of the cases, and in 12 of the cases, we were not able to we did a subtotal resection. And in one case, we just did a biopsy, or we did no treatment at all. On who histology, 22 were classic medulloblastoma, 9 were desmoplastic nodular type, only 3 were anaplastic, and 2 were the diffuse one. Now, molecular subgrouping, we had a chance. There was this twinning program with the Sick Children Hospital in Toronto, and we were very lucky to have one of our spearhead is Dr. Noreen Mishtaq. I wish she was here today because I have borrowed heavily on her stuff too. I wanted to thank her. She has a grant, a $500,000 of grant, and because of that grant, we were able to send our slides to for molecular classification to the Sick Children Hospital. And of those, 5 came as sonic hedgehog. 2 of them were sonic hedgehog with P53 mutation. 4 were want. 3 were group 3. 14 were group 4, and 2 were inconclusive. So with this thing now, the risk stratification, initially we were saying 20 were on the high risk group, the poor risk group. We were thinking of giving him high dose of radiation and all this stuff. But come to think of it now, 18 had the standard risk. In the standard risk, you don't have to give very high doses of chemotherapy and very high doses of radiation. So everything changes with molecular thing. With 2 of them were P53 mutation. We know that whatever we do, the prognosis is poor. So you have to tailor. Now in future, every tumor would have a tailored therapy with clonal antibodies and all that stuff. They were 20 were treated with ACNS protocol for chemotherapy, 7 were the ACNS. These are the 2 trials on which they were treated. 3 had no treatment, and 1 only had radiation therapy, and 5 didn't opt for any treatment over here because the treatments are costly at times. Patient family don't opt for the treatment. 25 of those people are still alive after 4 to 5 years. They are off therapy and they are thriving. 11 of them expired. They died. Of those 11, 5 of them expired because after the relapse. 2 of them expired during the treatment. Probably our treatment was too toxic. Expired. 1 of them expired during the surgery, and 1 of them expired during the RT, radiation therapy. So in conclusion, what I would like to say is that the more knowledge we have, molecular subgrouping is the way forward. I know it's costly, but the time would come, it would become and there would be even more subgroups. Now, even with the P53, people are talking about wild type and the mutant type, and MYC proteins proliferation, gene deletion, gene loss, gene gain. All these things would come if it's further subgroupings would come. With further subgroupings would come, we would have more knowledge. When we have more knowledge, we would be able to do better treat it. Like we know that the won't, and there are certain in subgroup 4, they don't need very high toxic treatment. So we have to curtail our treatment. We have to tailor our treatment with every case. More knowledge with this in future, every case, every tumor would be histopathology, subclassification, molecular biology, prescriptional studies. All these things would come into play, and after that, they would the treatment would come. Thank you very much. If you have any question.
Thank you very much, Dr. Sanbari. I don't think there will be any question, but I thought there should be little citation before the memorial lecture. As there was no citation, I think I should introduce Professor late Bashir Ahmed. He was known to most of us, but those who have joined recently in the neurosurgery, they may not be aware of this legend. He was pioneer in Punjab. He started neurosurgical department in National Medical College in early 60s and then transferred to King Edward Medical College and Mayo Hospital where he established neurosurgical department. And then he was asked to establish a unit in Lahore General Hospital where neurosurgery started, and Lahore General Hospital became synonymous with neurosurgery. In 1994, he retired, but before his retirement, he conceived the idea of Institute of Neurosciences, which later on, with the efforts of many senior neurosurgeons who became principals in Lahore General Hospital and Postgraduate Medical Institute, they worked hard, and now that institute is present in under the name of Punjab Institute of Neurosciences, which is now headed by Professor Khalid Mahmood. So Professor Bashir and Professor Juma, Professor Raja Iftikhar, Professor Javed Majid Mia, and many other neurosurgeons have a lot of contribution towards neurosurgery. So they'll be remembered in our lives. Thank you.
Thank you. Dr. Ehsan Bari, just one question. Dr. Ehsan Bari. This is Dr. Imran. Thank you very much for nice presentation. Just my question is that you said that if you leave, a little bit of residual tumor, then maybe 50% of the patient would not require VP shunt. But my worry is that I would be amazed that I think it depends on the site where you have left the residual. If, for example, you haven't seen the cerebral aqueduct after decompression, and the lower down, if you haven't addressed the lower pole, or you have left the residual at the level of cerebral aqueduct, in that case, I think that majority of the patient would require VP shunt. Although if you have leave the residual tumor at the base of the fourth ventricle, floor of the fourth ventricle, okay, in that case, maybe they would not require VP shunt. But if you have not seen the cerebral aqueduct, I think majority of these patients would require VP shunt.
Thank you very much, Dr. Imran. That's very kind of you to ask. Dr. Juma asked everybody a question except for me. I felt really neglected. So you have misunderstood my thing. I said leaving 1.5 centimeter, whether you do a near total maximum resection or if you do resection that leaves a little bit of the tumor, doesn't change the prognosis in the risk stratification. And I said that in 50% of the if you do a resection in the 50% of the cases, the patient would not need a shift. I did not say if you leave, if the fourth ventricle is blocked, naturally the patient would need a shunt. If it is not blocked, it is open. If you have opened it up, it would not need it. So depending, you are very, very right. You are very accurate. If it is blocking the aqueduct, would need a shunt. The patient would need shunt. He would have develop hydrocephalus. But if it is at the base of the fourth ventricle near the rhomboid fossa, then no, the aqueduct is open, the pathway is open, the patient would not need a shunt.
Sir, one question from my side.
Sure, sir.
Sir, I want to ask, I want to clear basically. We left the tumor, we left the unresectable part. Either we left it deliberately or it becomes unresectable, or its resection is more dangerous. That's why we leave it.
The thing is that if it is stuck to the brainstem, leave it, because that's going to cause more damage. So even if you leave a little bit, a sliver of the tumor out, it would not change the prognosis. If it is not changing the prognosis, why causing, my only thing is why causing anybody a neurological disability? Because that would, for the next 2 or 3 years, if the patient is paralyzed, even if you have taken the total tumor out, the patient family and patient wouldn't be happy. When the results are going to same, if you leave a little bit of a sliver, a small piece, the results are going to same. So it is causing a new onset disability, leaving a very small portion of the tumor. Ideally, we should try to remove, if it is possible, remove everything out. If you are able to remove it from the floor of the fourth ventricle without causing any damage, yes, you should remove it. If it is easily coming, if it is not easily coming, stay away. You don't have to be heroic. So
thank you, sir. This is what I want to listen.
I always say you are treating the patient. You are not treating an X-ray. It would really look good on a post-op MRI scan. There is no residual tumor, but the patient is totally vegetative. So that is no success.
Okay, thank you, Professor Sanbari. Thank you. I think let's finish with this session.
Thank you so much, Dr. Sanbari, for such a beautiful talk. Dr. Anjum Habib Vora and Dr. Abid, thank you so much for your presence. Now moving forward, can we have Dr. Mohammed Imran on stage, please? Thank you so much, Dr. Imran.
Okay. Assalamu alaikum. Bismillahirrahmanirrahim. I was asked to come on stage just to say a few words about one of our junior colleague, Dr. Majid Chandio, who is unfortunate that just 3 days back he was affected with and he was diagnosed as a case of Naegleria. And he was trained in Civil Hospital, Karachi. And he was a very nice chap. He was very humble person and a very young and dedicated neurosurgeon. And he was working in PNS Shifa as a consultant neurosurgeon. And just 3 days back, he was put on ventilator. He was in critical situation. And today he has just shown some signs of improvement. So I would just request you to pray for him and observe silence for 30 seconds and just pray for him. Thank you very much. Thank you very much.
Sorry for the delay. There's a bit of meeting going on. I think we have a surprise for some of our seniors, and it's someone's birthday today, so we're gonna have a cake cutting. So please be seated. The surprise will be revealed soon.